जाऊनी
आपण कोड बसच्या
as you know, Cuttack is a 1,000 years old city of the state of Odisha. Very commonly known, this is the silver city of Odisha. Now we are organizing this 42nd annual conference. We have two stages. One is physical and one organizing this symposium virtually. I am S.K. Mahapatra and I have two also co-chairpersons. Dr. Vishwaranjan Panda and Dr. Sanjay Behra, they are all with me. They are faculty from SC Medical College, Cuttack, the premier medical college of the state of Odisha. Now today we will be discussing a very important subject, a topic that is acute encephalitis syndrome. And we have a very eminent speaker as well, Dr. P.S. Karmakar. Now acute encephalitis syndrome is a critical public health concern in India. This health condition commonly affects young adults and children. And the clinical manifestations are characterized by acute onset of fever with clinical neurological manifestations like confusion, delirium, stupor, disorientation, and finally coma. Now it comes to my mind, you see there are two terminologies which are although very similar but they are different in their meanings. One is encephalopathy, the other one is encephalitis. Encephalopathy is a mental state that may affect due to many health conditions, whereas encephalitis is inflammation or swelling of the brain. It is caused by many causes. There are many reasons, starting from neurotrophic virus to bacteria to fungal to spirochetes to chemicals to poison to leptospira, and so many causes are there. So to highlight about the subject, we have none other than Professor P.S. Karmakar. Now he is the Professor Department of Medicine, College of Medicine, Kamarhati, Kolkata. He is a national, he has many national, international publications, more than 35 publications. He is a co-author of several books. Geriatric Health in India, book on obesity, API medicine updates every year since 2011. So I am very proud to have Professor S. Partha S. Karmakar to deal with the subject. Now over to you, Professor Karmakar. Professor Karmakar, please. Are you there? No. Am I audible to you, Professor Karmakar, please? Hello. Can you share your slides? Professor Karmakar, please.
You can start now, sir.
Yeah. Please start your deliberation. Am I not audible? Please raise your hand if I am audible.
Break from the phone. Okay.
Sir, share question.
Taଙ୍କର personal number contact करो. ताଙ୍କ number personal number contact.
ठीक ଅଛି ଛାଡୁ display ଦଉଛୁ.
Yes, कर्मा करूँ direct contact करूँ ले.
ଏଲି ସେ ପ୍ଲାଟଫର୍ମ ଅଛନ୍ତି ତ
ସେ
ତାଙ୍କର ସେ ଛାଡୁ ମୋଡ କରୁଛନ୍ତି.
ଆମର ସାଲେନ୍
ଏ କରୁଛନ୍ତି ତାଙ୍କ ପିକ୍ଚର ଟା କାଇଁ ସିଏ ଭିଡିଓ ଅଫ୍ କରିକି କଥା ହଉଛନ୍ତି. ସେମିତି ହବନି ନା ସେମିତି ନାହିଁ. ଖାଲି ବର୍ଷ ପାଣି ଦେଖୁଛୁ ଆମେ 3 ଜଣ ଆମେ ଦେଖୁଛୁ.
ତାଙ୍କର ଭିଡିଓଟା ଅନ୍ କରିନଥିଲେ.
ନମ୍ବର ତାକୁ ନା ଦଉନ
टाइम हेलाଣି हबो ना नहीं
କଟକ ମେଡିକାଲ କଲ ନିନ୍ଦା ହେଇଯିବ
हबो ना नहीं
କଣ ନମ୍ବର କାଇଁ ନମ୍ବର ନାହିଁ ଏଥିରେ ଆଉ
हां भाई ना
ତ କାକୁ ହଁ ସୁବିଲା
अरे सुबुज तो सबले पाठ काई
अरे स्पीकर अछंदी तांगर वीडियो हेलो
आई सेटा
Am I audible now? No, I am inviting this our speaker,
because yes invite the speaker and start
Professor P.S. Karmakar, please.
no, he is already ready
तांगर अछि कांटेक्ट नंबर
Dr. J.K. Sharma,
there
audio on.
Dr. Karmakar is there
Karmakar, but he is not able to listen to my voice. Dr. Sharma ji, am I audible to you?
Yes, sir, you are very much audible and I am ready.
Very good, but I am not able to connect Dr. Karmakar.
you can start with anybody who is
Would you like to start your deliberation?
Can I start my deliberation?
Third speaker.
Yeah.
नहीं जेके समय third speaker.
Yes, sir.
So, with the permission of the scientific chair and the chairpersons, I am going to start my deliberation in the next 18 minutes. I'll try to finish it, and the topic allotted to me is neurological blindness. Good afternoon to everyone, and I'm extending my thanks to the organizing committee and the scientific committee and the chairpersons of this session for giving me this opportunity to present before you the neurological blindness. Sirs, I am not a neurologist. I am basically a physician diabetologist. So if there are any shortcomings in the presentation, please forgive me for that. I will start with the introduction, then we'll talk about the optic neuritis, the visual pathway defects, and the occipital lobe syndromes. In between, at any time, if I'm not audible or if you cannot see my screen, please let me know. When we try to introduce the subject, the neurological vision impairment is loss of vision resulting from an acquired brain injury or impairment in the coordination of the eyes and difficulties with visual perception. And there is damage to the areas of the brain that are responsible for sight is involved. We can define it into as the mild, moderate, severe, and then comes the blindness. So the vision impairment can be mild if the visual acuity is worse than 6/12 to 6/18. The moderate when it is 6/18 to 6/60, and severe when the visual acuity versus than 6.60 to 3/60, and blindness when the visual acuity worse than 3/60. I would like to take you through this visual pathway when there is involvement of the cortex. Then there is a role of the optic nerves, bilateral optic nerves, then the optic chiasma, the lateral geniculate nucleus, the superior colliculus, and then coming to the virtual cortex. So the optic neuropathies, the inflammatory optic neuropathy is the most common cause of optic neuropathy in the young adults, and the ischemic optic neuropathy is the most common etiology in older subjects. It is characterized by acute or subacute, often painful vision loss that results from inflammation of the optic nerve, and the vast majority of patients with inflammatory optic neuropathy have optic neuritis, a nerve inflammation secondary to demyelination. In many patients, the optic neuritis is the heralding manifestation of multiple sclerosis. So we have to differentiate this with the multiple sclerosis. The peak incidence in the 3rd and 4th decades, female to male ratio is 2:1, and the prevalence is 1 and 6.4 new cases per year per 1 lakh population. Now, the symptomology of optic neuritis is there is pain which is most often precedes the vision loss by a few days and is present in the majority of the patients. Globe tenderness is there, worsening of the pain on eye movements are typical. Pain is significantly more common in the retrobulbar neuritis as compared to the papillitis, and any pain in the globe is short-lived, and persistent pain which is more than 7 days should prompt an evaluation for the local disease like the systemic inflammatory condition, scleritis, malignant glioma, orbital inflammatory syndrome, the aneurysm, or a sinus mucosal. And this is because of the stretch of the dural sheath around an inflamed and swollen optic nerve. Now, there is one syndrome known as the Uthop syndrome or the Uthop symptoms, which is a transient visual obscuration associated with elevation in the body temperature, and it is seen with multiple sclerosis. It can be provoked by as little as hot food or cooking, but most typically is brought on by the physical exertion or a hot shower. Minutes to 1 hour later, vision returns to baseline without any residual deficit, and this is very classical of multiple sclerosis. It has been described in hereditary, toxic, compressive, and sarcoid optic neuropathies, and presence of Uthop symptoms may be a poor prognostic indicator which correlates with the white matter lesion on the MRI and future risk of multiple sclerosis and recurrent optic neuritis. Now, the neuroophthalmic signs are contrast sensitivity was measurably abnormal in 98% patients with optic neuritis treatment target or treatment trial when compared with the age-matched control. And this is the most sensitive indicator of visual dysfunction in acute and recovered optic neuritis. There is visual field loss. Most common visual field defects in optic neuritis are the central scotomas. Any type of visual defect, field defect may occur in multiple sclerosis due to involvement of the optic tracts, which I will further let you know how they are presented. Except bitemporal hemianopia, which is more characteristic of the suprachiasmatic tumors. A defect that extends to the periphery should suggest a compressive lesion. Altitudinal defect, particularly an inferior altitudinal defect, is more common in anterior ischemic optic neuropathy. The fundus in retrobulbar neuritis is normal in around 2/3 of the patients, and in papillitis, the lesion involves the head of the optic nerve. That is, in 1/3 cases, the disc edema may be seen, but no retinal hemorrhage, no cotton wool spots, and no exudates. Optic atrophy is frequently found after the acute episode resolves, and the disc becomes pale as a result of the axonal loss, and this pallor predominates in the temporal segment of the disc, and that is known as the temporal pallor. Temporal half of the disc is normally paler than the nasal side. When we go for the magnetic resonance imaging in optic neuritis, the optic nerve inflammation can be demonstrated in about 95% of the patients with optic neuritis with gadolinium contrast enhanced MRI of the brain and orbits. And there are specific sequences on the MRI to look for the optic neuritis, but they are of much of the use of the radiologist and the neurologist, which we can see here. The orbital MRIs in patients with acute optic neuritis, more diffuse enhancement of the right optic nerve, which we can see here. Now, what is the course of the optic neuritis? Optic neuritis may develop into the multiple sclerosis, or it may develop neuromyelitis optica, which is also known as Davick's disease. Is a rare condition where the immune system damages the spinal cord and nerves of the eye, that is the optic nerves. This neuromyelitis optica can affect anyone at any age, but it is more common in women than men. There may be recurrent optic neuritis, and there may be isolated optic neuritis also. This is the cause. When we talk of the prognostic factors, there are good prognostic factors when there is not developing into the multiple sclerosis, but there are poor prognostic factors which favor developing into the multiple sclerosis. The good prognostic factors are male gender, absence of pain, presence of optic disc swelling, peripapillary hemorrhages or retinal exudates, history of preceding infection within 2 weeks of an onset, and no light perception in the affected area, and optic neuritis in children. They have a good prognosis. The poor prognosis, when there are recurrent or bilateral sequential optic neuritis, presence of cerebral MRI lesions accompanying an isolated episode of optic neuritis, presence of oligoclonal bands in the cerebrospinal fluid, the HLA-DR2 genotype, young age at onset, female sex, and presence of venous sheathing. These are the poor prognostic factors. And these are the various neurological diseases affecting the optic nerve, and they are optic neuritis, non-arthritic ischemic optic neuropathy, arthritic ischemic optic neuropathy, then the Leber's hereditary optic neuropathy, and the neuroretinitis. I will not go in details because they have been mentioned here, and they have been compared regarding the age, gender, pain, onset, unilateral, bilateral, fundoscopic examination, visual field defect, prognosis, and the MRI and MRI of the optic nerve findings. But I will not go into the detail. Now, coming to the visual field defects, there may be hemianopia, and hemianopia is impaired vision in half of the visual field. We can see on the right side, there is homonymous hemianopia and heteronymous hemianopia. The hemianopia defect does not cross the vertical meridian, which is very classical, and it is of two types. It may be homonymous when the same side of the visual field is affected, and heteronymous, impaired vision in opposite halves of each eye, right of one eye and left of the another eye. The heteronymous hemianopia, the lesion is at the chiasmal lesion. It may be bilateral. It is rarely binasal. When we talk of the bitemporal chiasmatic lesion, because of the anterior inferior position of the decusating inferior nasal fibers, lesion impinging from below, they produce the upper temporal field defect, which evolved into bilateral hemianopia. Example is like that in the pituitary adenoma, and lesion encroaching from above tend to cause inferior field defect initially, later evolved into the bitemporal homonymous hemianopia. that like in craniopharyngioma, and others are the suprasellar aneurysms, meningioma, and the third ventricle glioma. The binasal hemianopia, that is the chiasmal lesions, they are very rare and from disease impinging on the lateral aspect of the chiasm on the both sides, like that in the bilateral intracavernous internal carotid aneurysm, distension of third ventricle causing pressure on each side of optic chiasma, and atheroma of carotid and posterior communicating arteries. The homonymous hemianopia, they are caused by lesion posterior to the optic chiasm, and the vision is lost in ipsilateral nasal field and contralateral temporal field. There are two types. They may be complete, they may be incomplete. Incomplete are again of two types: incongruous, differently shaped defect in both the eyes, and lesion site is anterior lesion. Congruous, similarly shaped defect, and lesion site is the posterior lesion. And in complete hemianopia, congruity cannot be assessed. Now, this is the diagram showing the site of lesion and visual field defect. We can see here that if the lesion is at the optic nerve, then you can see here there is total loss of vision on one side, visual field defect. Then if it is at the optic chiasma, then at the third level, then if it is at the optic nerve, so these are the various lesions depending on where exactly the lesion is. Now coming to the cortical lesions or the visual cortex and the visual association area. Each occipital lobe receives the projection from the nasal half of the opposite retina and the temporal half of the ipsilateral retina. The superior and inferior retinal projections, they extend to the superior and inferior lips of the calcarine fissure, and the macular retina is represented towards the posterior pole of the calcarine cortex. The foveal representation is located at the occipital lobe, and the extreme periphery of the visual field is represented anterior at the junction of calcarine and the PO fissure, and the central 10 to 15 degree of the vision fill a majority of the total surface area of the occipital cortex. Now, more common, due to the embolism from the heart, aorta, or the vertebral arteries, there is posterior cerebral artery territory infarcts. Atherosclerosis and dissection of the posterior cerebral artery is not common. There is vision loss, and there is sensory and motor lesion also, like lateral thalamic infarction, which is the major reason for the somatosensory symptoms and signs. Patients describe paresthesias or numbness in the face, limbs, and the trunk. The combination of hemisensory loss and hemianopia without paralysis is virtually diagnostic of infarction in the posterior cerebral artery territory. The occlusion lesion is within the PCA before the thalamo-geniculate branches to the lateral thalamus. Rarely, occlusion of the proximal portion of the PCA causes a hemiplegia, which is probably due to infarction in the lateral midbrain. Now, the left posterior cerebral artery infarction is there when the left PCA territory is infarcted, alexia without agraphia, anomic aphasia, or transcortical sensory aphasia, and the Gustman syndrome like the acalculia, agraphia, finger agnosia, and right-left disorientation are seen in this left PCA infarction. In right PCA infarction, infarct of the right PCA territory, they are often accompanied by prosopagnosia, which is difficulty in recognizing the familiar faces. There is disorientation to place and an inability to recall routes or to read or visualize the location of places on maps are also common. Patients with right occipitotemporal infarct also may have difficulty visualizing what a given object or person looks like, and dreams may be devoid of visual imagery. Visual neglect is much more common after lesions of the right half of the left PCA territory. And this is the table showing the defect, the localization, and the associated symptoms. Where is the defect, where is it localized, and what is associated symptoms. Now, there is one syndrome known as the Anton syndrome. When there is lesion in bilateral occipital lobe, also known as the Antoni-Babinski syndrome, is visual anosognosia, that is denial of loss of vision. The person says that I can see, associated with confabulation defined as the emergence of memories of events and experiences which never took place in the setting of obvious visual loss and the cortical blindness. Another syndrome, which is the Balint syndrome, described initially as a rare disorder associated with difficulties in visual and spatial coordination and is characterized by the three cardinal features: lesions in bilateral parieto-occipital area, and the lesions are optic ataxia, which is lack of coordination between visual input and the hand movements. Oculomotor apraxia is the inability to voluntarily shift gaze despite the intact function of extraocular muscles, and simultagnosia is the lack of ability to perceive more than a single object at a time. With that, I finish. Thank you very much. If there has been any fallacy, please excuse me for that, because I'm not a neurologist. Thank you very much. Sir, you are muted, sir. Sir, you are muted. Sir, I can't hear you. You are muted.
Mutation. Unmute yourself. Yeah.
Yes, sir.
Audible?
Yeah.
Yes, sir.
Yes. So thank you, Dr. Sharma. Although you are not a neurologist, but your deliberation was more than a neurologist, encompassing all the aspects of neurological blindness. So thank you very much. If you have time, you can wait up to the end of the session. Otherwise, you will take some questions from the audience. Then I think you can be free. And before that, I would like to give my co-chairman, Dr. Sanjay Behera, to invite a question from the delegates.
Thank you, Dr. Sharma, for your nice presentation and details about the neurological blindness. Sir, I have one doubt. If the neurological blindness is by definition, it is a loss of vision due to acquired brain injury, is there any hereditary or congenital cause of any neurological blindness?
Sir, I have gone through the literature, but I did not find any such cause which has, and I discussed with my neurology friend also, but I don't have any answer to this question. Maybe some neurologists can tell us.
Okay, sir. Thank you.
Yes.
Thank you.
Yes, sir.
Please.
So can I? Yeah, thank you, Dr. Sharma. Very nice presentation. I am sitting inside a eye hospital, a tertiary care eye hospital. So what our experience from here regarding the incidence and prevalence of optic neuritis. So we find, though the multiple sclerosis is the number one cause of optic neuritis, for that we in India and with this part of country, we don't find much of multiple sclerosis. We find stray cases, but we find the enormous spectrum of disorders. That is the neuromyelitis optica spectrum of disorders. That is the number one cause of optic neuritis, which we find in this young generation from our institution. Number two, you have shown that ischemic optic, that the arterial ischemic optic neuropathy. But there is one other term you have also shown in one of the slide. That is a non-arteritic arterial ischemic optic neuropathy. That is what we found in many patients. That starting from the young to the elderly people, that is one of the most common causes of optic neuropathy. And thirdly, yes, we found cortical blindnesses here and there. We found that cortical blindness also. So these are the three spectrum of neurological blindness, neurological optic that causes. But we found in our this tertiary care institute and whole institute.
Thank you, sir.
Now, any other questions from the audience or any comments, any suggestions? If there are no such, then I think thank you very much, Dr. Sharma. We met last time at Chennai and hope
Yes,
we will
sir.
be meeting in Ahmedabad as well.
Yes, sir. Thank you very much, sir. Thank you, sir.
Thank you so much. Okay, thank you very much.
Good day to all.
Okay, fine. All the best. If you like to stay, you can stay. Otherwise, if you are busy, also.
Sir, I will have to leave. Thank you, sir.
Okay, thank you very much. All the best. So I think next we will go to the first topic,
Yes, sir. I'm ready, sir.
Sir, I just introduced about the subject. Probably there was some virtual disconnection.
Yeah, yeah.
Not able to connect each other in appropriate time. But it's a very interesting subject that you have been able to give a deliberation on the subject. I find this acute encephalitis syndrome is really a very critical public health concern in India. And it generally affects young adults and children. And it is characterized by acute onset of fever with the neurological symptoms like confusion, delirium, discoordination, stupor, coma. And actually, there are several causes, but we find commonly those neurotrophic viruses that are responsible for this encephalitis syndrome. There are also can cause this encephalitis syndrome. There are two very common words, terminologies, encephalopathy and encephalitis. Usually physicians and clinicians, they do confuse these two similar words, but actually they are meaning wise dissimilar. Encephalopathy is a mental state because of many health conditions, whereas encephalitis is inflammation or swelling of the brain. So with this, we have a very renowned Professor Dr. Partho S. Karmakar. He is the Professor, Department of Medicine, Karmahati Medical College, Kolkata. He has many national and international publications, about more than 35 publications. And he is a co-author of several books. Geriatric Health in India, book on obesity, API medicine updates every year since for about more than a decade. So with this, I cordially invite Professor P.S. Karmakar to start his deliberations on the subject, encephalitic syndromes. But actually, Dr. Karmakar, I found it's everywhere it is mentioned only encephalitis. So kindly just give confusion whether encephalitis is the appropriate term or encephalitis is the appropriate term. With this, I request you to kindly start your deliberation. Welcome.
Okay, sir. Okay, sir. Am I audible, sir?
Yeah, very well.
Okay, thank you, sir. And good afternoon, chairpersons. With due respect to all of you and the learned gathering, I will now deal another very important neurological topic, that is acute encephalitis syndrome. And I am really thankful to chairperson for all those kind words. I will definitely try to explain whatever he has told me at the very outset of my of his introduction. And at the outset, I express my heartfelt gratitude to all the organizing committee members, Dr. John Pandey in particular, for giving me this chance to have discussions on this important topic with the learned gathering, that is acute encephalitis syndrome, which is abbreviated as AES. Sometimes AES is more popularly known than acute encephalitis syndrome. So I will try to touch upon this important topic by briefly touching upon these points: introduction and what is the epidemiology and etiology of AES, that is acute encephalitis syndrome. Various AES infections, there are various etiology of AES, could be viral, bacterial, non-infectious, and there could be some clinical clues to differentiate various AES investigations, management, and take-home message. So next slide, please. Next slide. So next. So so far introduction is concerned, the other name of AES is brain fever, and it's a major public health problem in India. And why there, as our chairperson sir is emphasizing, why it is acute encephalitis syndrome rather than encephalitis we used to know in our student life, that only encephalitis. Because encephalitis syndrome has been coined by World Health Organization in 2006, because there is a set of neurological, there are similar set of neurological manifestations caused by, next slide please, set of similar neurological manifestations caused by several different viruses, bacteria, parasites, which can mimic viral encephalitis. so that we will not miss the other causes of viral, other causes of encephalitis than viruses. For that reason, we have coined the term acute encephalitis syndrome, coined by WHO, so that the other causes of encephalitis will not be missed out. If we remember this acute encephalitis syndrome, which could be as a result of various other infections or non-infectious materials too. That is the reason. And in acute encephalitis syndrome, what we have to keep, because we need to diagnose it very promptly within a day or two, because we will get a very small period of time to treat the patient and to save patient's life as well as their morbidity. Next slide, please. So how do we define acute encephalitis syndrome? As our chairperson has already said, that it is an acute onset of fever in a patient of any age at any time of year, and high rise of temperature of acute onset, and there is a change in mental status, either in the form of confusion, disorientation, coma, or inability to talk. But we have to be very careful not to, we have to exclude the simple febrile seizure. Next slide, please. So what are the different causes which could be brought under the umbrella of acute encephalitis syndrome? Not only the virus, which means the encephalitis only. So definitely the virus is the prototype of all sorts of AES, and along the viral, and we divide into the causes into viral, non-viral infections, and non-infectious inflammations of the cerebral hemisphere. Among these infectious inflammations, the virus is definitely the prototype of all AES, and among the all viral causes, that is JE virus, Japanese E encephalitis virus, is the most prevalent in India, and JE virus, that is a group of flavivirus, major causes of AES in India, both in pediatrics and adult. And other than JE virus, other viruses that are also able to produce AES, that is acute encephalitis syndrome, are herpes simplex virus encephalitis, chikungunya, dengue, Nipah, and Chandipura. So these are the important viruses which could be seen in India for production or for the disease of AES. But we shouldn't forget, we have just overcome the COVID-19 encephalitis. COVID-19 is also associated with encephalitis, AES, because of their predilection in the nasopharynx and the oropharynx, they can directly get entry to the CNS through the first cranial nerve olfactory bulb. So that is to be also kept in mind, that it could be COVID infection could be one of the important viral causes after JEV as well as HSV. Now, non-viral infectious causes which are very important in our country, that is bacterial, parasitic, spirochetal infections, fungal, and rickettsia. Among them, the parasitic infections, malaria, and the rickettsial infections, scrub typhus, are really increasing for the last 2 decades as one of the important causes of AES. Next slide, please. So among the various etiologies of AES, what is to be kept in mind in this cartoon I have shown, that in the lower part, it is shown that there are some unknown causes. Even after this modern medicine, all sorts of very modern investigations are being available. So there are even 30 to 50% of cases, still we cannot diagnose which could be the underlying cause for AES. So if we go, next slide, please. If we go for, flow chart for the etiology of acute encephalitis syndrome in India, preferably, then we should divide into infective and non-infective autoimmune causes of AES. Among the infective, again, we should divide into 2, viral and non-viral. Among the non-viral, bacteria, parasite, rickettsia, all could be the important etiological factors. But among the viral, which is the big brother among all the causes of AES, the JE virus is really a big brother, and the causes almost 40% of all viral virus-related AES is caused by JE virus, that is Japanese encephalitis virus. And non-JE virus are the rest, among which HSV, that is herpes simplex virus, is a very important virus after JE for the causes of viral related AES. Now, epidemiology. So far, epidemiology is concerned, the epidemiology in India is gradually changing, because in our studenthood, we all the time thinking about the encephalitis on the virus. But as the AES has been coined, the term by WHO in 2006, we include not only the virus, but various other non-viral causes of inflammations of the cerebral hemisphere can cause AES. And among them, autoimmune encephalitis syndrome and staph typhus AES are really increasing to a great extent in last 2 decades. So we shouldn't forget, whenever we are coming across a patient of encephalitis-like syndrome, we have to think along with the virus, we should give equal importance to autoimmune as well as staph typhus induced acute encephalitis syndrome. Now, we have to know, because the Japanese encephalitis virus is the most common cause of viral encephalitis, we should know 1 or 2 points that should be kept in mind. The first outbreak in India occurred in Bankura in West Bengal, 1973. And the sad part of JE virus encephalitis is there is high mortality. There is 30% of patients die even after proper therapy. And the remaining 30 to 50% will show residual psychiatric as well as neurologic problems. So morbidity is very high, and mortality is also very high, to the tune of 30%. And after our awareness about this, the mortality has decreased to a great extent. And according to our statistics, in 2018, 10,400 cases, 630 almost died. That is, from 2014 to 2018, within 4 years, we have seen a rapid reductions of mortality from almost 17% to 6%. So what are the differences? Can we have as I have said, that Japanese encephalitis is the big brother that is causing 40% of viral encephalitis on the bedside. Can we get some clue so that we can come to almost a platform that it is a non-JE virus related encephalitis or JE virus? Because we don't have any other therapy other than supportive therapy in JE virus, but other viruses, especially the HSV virus, herpes simplex virus, we do have definitive therapy for that. So, on the bedside, if we try to go for some clinical clues, there you will see if there is presence of rash, if there is bilateral symmetrical neurological deficits, and if there is jaundice. So if there is rash, bilateral symmetrical neurological problem, and there is jaundice, you can clinically say that it is probably non-JE virus related AES. So these are the 3 very important clues, whether it is a JE virus related or non-JE virus related encephalitis. And another some clues you have to bank upon. These are pallor, icterus, skin rashes, petechiae, and parotid swelling and orchitis. Because these also can give a very important clue what could be the underlying etiology for this acute encephalitis syndrome. If there is pallor, severe pallor, you can think of cerebral malaria could be the cause of AES. Icterus, leptospirosis or cerebral malaria could be the indicator. If there is skin rashes along with AES, dengue, measles, varicella, and rickettsial diseases are to be thought of. And if there is petechiae, dengue, viral hemorrhagic fevers, as well as leptospirosis should be thought of. And if there is parotid swelling with orchitis, mumps should be considered as a cause of acute encephalitis syndrome. So these are the very important general survey points which we can that can give a very important clue so far the underlying pathophysiology of acute encephalitis syndrome. Now coming to the, after brief discussion of infective causes of AES, now coming to the non-infective causes of AES. Among the non-infective causes, autoimmune encephalitis holds the very important place, and here now it is really increasingly being recognized. Please, hello.
Next slide.
Please change the slide. I have forgotten to tell you. Please change the slides. Next. Yeah, please, sir. So after a discussion on the infective causes of AES, now autoimmune encephalitis is another very important domain of AES. And here what we do find that there are some antibody formations against the neuronal cells and intracellular proteins. That antigen antibody reaction can give rise to autoimmune encephalitis. And these autoimmune encephalitis could be tumor associated as well as non-tumor associated. There are lots of antibodies which can produce AES, and every year some other antibodies are being added to this. So the domain has increased a lot, and because of our concern and our effort for going for this sort of advanced investigations, and we can find out that autoimmune encephalitis really produces a good chunk of all sorts of AES, all common causes of AES. And anti-NMDA antibody, anti-LGI1 antibody, these are the extracellular neuronal cell antibody, and some intercellular antigens, that is anti-HU, that is being found in small cell lung tumor, the GABA-A, GABA-2, GABA-B, all these are receptor antibody which can produce autoimmune related encephalitis. So the cause for these antigen antibody reactions is nothing but the molecular mimicry with that neurological protein. Next slide, please. So non-tumor related autoimmune encephalitis, two important causes among them are SLE and SLE that can produce anti-nuclear antibody and can produce autoimmune encephalitis, and another is Hashimoto encephalopathy. Though majority of the endocrinologists are not in favor of Hashimoto encephalopathy to be called as encephalitis, because it's in real sense encephalopathy, what my chairperson was emphasizing, that there is little bit difference between encephalitis and encephalopathy. Encephalopathy means suppression of brain function not due to inflammations, but encephalitis means due to inflammation, suppression of brain function is there. And points worthy to be remembered so far autoimmune encephalitis is concerned, that sometimes encephalitis, acute encephalitis syndrome may antedate the manifestations of tumor, whether it is ovarian teratoma where NMDA is being found, or some other tumor like anti-HU, that is in small cell carcinoma of lung is concerned. So sometimes the autoimmune encephalitis is the feature may antedate the tumor manifestations, and usually it affects young adult and children, and may respond to therapy, either anti-tumor therapy or some immunosuppressive drugs that I will take upon in my later slides. So there are some AES mimickers. So it is not AES, but it can behave like AES, and we may make some mistake so far our diagnosis is concerned. So we have to be very careful that whether we are dealing with ADEM, that is acute disseminated encephalomyelitis, or Baker's brainstem infections, Hashimoto's encephalopathy, they are all associated with sensorial alteration. And there are some drugs and toxins, including alcohol, that can induce encephalopathy and may mimic AES. And metabolic encephalopathy due to liver failure and other dyselectrolytemia like hyponatremia can also produce AES-like manifestations. But the most important part is there is absence of fever. So if there is absence of acute onset of fever, we have to think about the possibility of AES mimicker. Now coming to the investigation.
Just interruption, excuse me, to ask them to change slides.
Yeah. Oh, yes. Please change your slide.
Yeah.
Okay. Sorry, sir. Please, next. Next. Hello, next. Next, sir. So investigation. So whenever we will investigate a case of encephalitis, we have to remember that as AES, viral origin is the most common cause. So a prototype of all AES, our investigations are preferably made in reference to viral encephalitis. But we have to give emphasis to find out very quickly the treatable causes of encephalitis, because we can reduce mortality and morbidity of encephalitis-related morbidity and mortality to a great extent if we can institute therapy very quickly. Next slide, please.
Yes.
So what are the investigations we should go for whenever we have thought about our DD, thought about our diagnosis of acute encephalitis syndrome, we have to keep remember the disease that is viral as well as non-viral infective causes and the non-infective autoimmune causes. So apart from the basic investigations, the most important investigation of first choice is lumbar puncture if patient is stable and patient is not having raised intracranial tension. In that case, lumbar puncture is the first important choice investigations for AES. And we should go for, after collecting CSF, we should go for cell count, its total count, differential count, as well as the viral panel through PCR. What are the we should go for full viral panel as along with routine investigations. So, and that can give a very important clue whether that encephalitis could be viral, tuberculous, or bacterial origin. And the second important choice, that is neuroimaging, and neuroimaging, especially the MRI, becomes the first investigation of choice if LP is we are not being able because of the patient's unstable conditions or raised intracranial tension within 6 hours. If we cannot go for LP within 6 hours, then MRI of brain is the first investigation of choice and may give a valuable information so far whether there is a bleed inside the cerebral hemisphere or cerebral edema. And MRI has revolutionized the diagnosis of AES so far its etiology is concerned according to its specific manifestations in MRI. So far the underlying pathophysiology is concerned. And third important investigation is serology, because by detection of specific IgM antibody against the virus, suspected virus, within 1 to 3 months, if it is being found in CSF and in serum, then the diagnosis is absolutely confirmed. And sometimes if we think of autoimmune encephalitis, we should go for some autoimmune serological investigations too. So neuroimaging, so far MRI, as it has revolutionized, I will just jot down a few important manifestations that is being found in MRI, and we can.
2 minutes left, please.
Okay, sir. I will finish, and we can jolly well be very stand on a very concrete platform. What could be the diagnosis? In herpes simplex, there is asymmetrical involvement of temporal lobes and frontal lobes. And in Japanese encephalitis, thalamus, basal ganglia, and brainstem. So far the viral causes of investigations are concerned. Next slide, please. We have to be very careful, and I will show a few slides of that after my next slide. So here I have already emphasized that we have to be very careful. If we can exclude the viral etiology, we have to bank upon whether the patient has been suffering from cerebral malaria by thick and thin film, as well as the dual antigen through rapid detection test, as well as IgM for scrub typhus. So these are the three things sometimes we do forget. We should go for, along with the CSF study, we should go for blood test of these MP parasitic infections as well as rickettsial infections, IgM against scrub typhus. Next presentation, for the lack of time, I am not going for case presentation, but I will show definitely one thing. Next slide, please. Next slide. Next slide. Next slide. This patient was admitted in under my care in my institute, and it shows very vividly that there is asymmetrical involvement in T2 flare, that is hyperintense lesions, more on the left side than on the right side. This asymmetrical involvement of temporoparietal region is very, very classic of herpes simplex encephalitis. Next slide, please. Next slide. Next, please. Now, this is another classical example of herpes simplex encephalitis. Next slide, please. This is the basal ganglia involvement, bilateral symmetrical basal ganglia involvement in a AES patient. If this sort of hyperintense lesions in T2 MRI is being found, it is very much classical presentation of JE virus. So 40% of the viral infections are due to JE virus. So next slide, please. So from diagnosis, what is the most important part? When the patient has come to you with fever and altered sensorium plus minus seizure, our diagnosis is AES. But whenever we are discharging, that AES should not be your discharge diagnosis. That diagnosis should be not AES, but the discharge diagnosis should be according to the pathophysiology of this, either JE virus encephalitis or scalp types of encephalitis like that. So we shouldn't make that mistake that AES should be our discharge diagnosis. So despite thorough investigations, even in our modern medicines, that is 37, that is 1/3 to 2/3 patients still remain undiagnosed. So that is to be kept in mind. So far management is concerned, majority of when we cannot find out any etiology, only we have to bank upon the supportive therapy, that is maintenance of intravenous fluid to avoid any sort of dehydration. Then the therapy for intracranial pressure, we all know. And if there is seizure, we have to put on patients on anti-epileptic drugs in the form of lorazepam, diazepam, or midazolam. And the most important part, that is, if we cannot find out any cause promptly, or while the test results are pending, if our diagnosis is AES of infective origin, we should put patients on 4 drugs. There is no harm to put and no irrationality if we put patients on 4 drugs, because to save life. Because one is acyclovir, which is the drug for HSP. Please, next slide, please. Next slide, please. Next slide. Next slide. Yeah. So if we put 4 drugs, that is, one is acyclovir, that is very much the drug for HSV, herpes simplex encephalitis. Then broad spectrum antibiotic ceftriaxone to tackle any bacterial infections, bacterial meningitis, or meningitis along with encephalitis, anti-rickettsial, doxycycline, or azithromycin, and anti-malaria. All these 4 drugs could be put together in a patient when AES is the diagnosis and while the reports are being awaited. And if we think of autoimmune encephalitis, we have to, in collaboration with neurological friend, we have to chalk out our investigations as well as therapy. And in AI, that is autoimmune encephalitis, steroids, rituximab, as well as plasma exchange could be of great help, along with, if it is in relation to tumor, therapy of the tumor is to be instituted. So far, take-home message is concerned. So the important salient points that is to be kept in mind is AES of viral origin is the prototype of all AES. And AES, next slide, please.
Oh, yes.
Yeah. AES of viral origin is the prototype of all AES. AES JE virus are the main causative agent of acute encephalitis syndrome in Asia, including India. And Japanese encephalitis virus, the important point that is, it is unlikely to be one of the causes, one of the disease in acute encephalitis syndrome out of several causes. If there is presence of rash, jaundice, symmetrical neurological involvement, you can, on clinical basis, if these are there, you can jolly well exclude the possibility of JE virus related AES. The epidemiology of AES is gradually changing, and rickettsia, that is scalp typhus, as well as autoimmune encephalitis is really increasing like anything in last 2 decades. Next slide, please. And identification of treatable causes should get preference so far investigation is concerned. And AES is only admission diagnosis, not a discharge diagnosis. And 1/3 to 2/3 of patients with encephalitis, even after all sorts of investigation, remain undiagnosed. And there is no harm, no irrationality. If you really coming with a patient of AES in acute stage, put patients on acyclovir, broad spectrum antibiotic ceftriaxone, anti-rickettsial, doxycycline, and anti-malarial. There is no irrationality, because saving life is the most important part so far AES diagnosis and treatment is concerned, while you are waiting for the test results. Thank you. These are my references, and thank you for your patient hearing.
Thank
Over
you.
to Japan, sir.
It was really very educative and informative. We have covered all the aspects of this acute encephalitis syndrome. Just I wanted to know why this is more associated in young adults and children, and why it is not.
You are not audible, sir.
Hello.
Yeah. Sir, young adult and children, they are going outside for some work, some play is more common. So it's For them, it is they are coming with other interactions with other physically with other people or more compared to the elderly persons or above 40, 60 years. That's the reason they can contract the viral infections.
Why this SL is more common in producing encephalitis rather than other autoimmune diseases? Is there anything specific?
Yes, sir. Yes, sir. I mean, our study is concerned as well as the recent advances say. So there is no comparison between SLE as well as autoimmune because our tumor-associated autoimmune encephalitis, majority of them are not being diagnosed properly. So whenever patient AES is coming, antedate the tumor-related thing, tumor has not yet appeared clinically, but patient has come to AES. So that's why we can miss. But whenever SLE is a full-blown SLE or something like that, it is clinical diagnosis is very common. That's why you don't miss it.
So, okay, thank you very much for joining as a speaker in our 42nd annual conference of APICON Odisha chapter.
Okay, sir, thank you.
I think we will meet at Ahmedabad next APICON national.
Definitely, sir. Definitely.
Thank you and welcome.
Okay.
I think there are no questions from the audience. So with this, we will close your topic and thank you so much. Now
Okay,
I
sir,
hand
thank
over
you.
the mic to my co-chairperson for Dr. Biswaranjan Panda for making proceedings on next topic, acute pancreatitis. So he will be inviting Professor Rajesh Upadhyay. Dr. Biswaranjan Panda, please.
विश्वरंजन पंडा आपको फोन करो राजेश ये नेशनल एपीआई के लिए चेयरमैन ना
Good evening, everyone. Thank you very much, Dr. Jain Panda, organizing chairman, and also my chairpersons. My topic is hypertension in elderly management, a pellucid approach. Am I audible?
Sir, yes.
Okay. I'll share one by one. So we all know hypertension is an abnormal elevation of blood pressure due to increase in cardiac output and peripheral vascular resistance. So if we make to reduce cardiac output and peripheral vascular resistance, the blood pressure will be controlled well. What is the significance of hypertension in the elderly? It is related to adverse CV outcomes, heart failure, stroke, myocardial infarction, and finally death. The global burden of hypertension is rather increasing due to an aging population and increasing prevalence of obesity, and is rather estimated to affect 1/3 of the world population by 2025. The adverse outcomes in older adults are compounded by mechanical hemodynamic changes. Number 2, arterial stiffness, then neurohormonal and autonomic dysregulation, and declining renal function. So what are the management strategies? In older adults, we must consider the degree of frailty, the increasingly complex medical comorbidities, psychosocial factors, so it has to be individualized. And non-pharmacological lifestyle interventions should be encouraged to mitigate the risk of developing hypertension and as an adjuvant therapy to reduce the need for medications. The pharmacological therapy with the diuretics, RAS, renin-angiotensin system blockers, CCB calcium channel blockers, all have shown benefit on CV outcome in older patients. The essential point is the economic and public health burden of hypertension globally, so it is rather critical to address lifestyle modification in younger generations to prevent hypertension with age. So what is the definition of old age? The UN definition of old age is more than 60 years. The World Health Organization definition of old age is more than 50 years. The clinical experimental emergency medicine classified old age into 3 groups: youngest to old, ages 65 to 74, middle to old 75 to 84, oldest to old is 85 and more than 85. This is a Korean Society of Emergency Medicine 2018. So these are all the definition of hypertension, that is 130/80 ACC-AHA, that is 140/90 ESC-ESH. Additional differences when addressing the risk of goals in order, that is in older people 130/70 to 139/79, that is ESC-ESH, but less than 130/80 millimeter for ACC and AHA. The newer lower threshold have now been included more patients as hypertensives. So hypertension, it has got a significant effects on CVD outcomes, heart failure, myocardial infarction, stroke. The asymptomatic quality of systemic hypertension can rather delay the diagnosis. It prompts the initiation of optimal therapies. As with many conditions, hypertension increases with age, prevalence increasing from 27% aged, that is younger than 60 years, increasing to 74% in those aged older than 80 years. The Framingham Heart Study, US study, they all show the people that is gaining momentum. That is, more than 90% of participants with a normal blood pressure at the age of 55 eventually develop hypertension. That is Framingham Heart Study. US study, up to 50% of people born in US today will reach the 100th year. With the rapidity of aging population, the prevalence of hypertension can only be expected to rise. The striking points, what is striking in several studies that focused on guiding screening on management of hypertension traditionally excluded older adults, especially above 80 years. So treating elevated BP in older adults has therefore remained controversial. However, recent data demonstrate cardiovascular disease benefits in treating hypertension in older adults. This emanates from several key studies. That is UKPDS, SHEP systolic hypertension, that is Cyst Europe, Medical Research Council Working Party, then hypertension in the very elderly age group, elderly people. So the recognition and appropriate treatment of hypertension in older adults should be a priority for physicians. So let us review and aim to address the challenges in assessment and management of hypertension in older adults, as well as to address the differences among guidelines and societies. There are specific underlying mechanisms of hypertension in older adults. Number 1, mechanical hemodynamic changes. 2, we all know arterial stiffness. 3, neurohormonal and autonomic dysregulation. Then aging kidney. Aging results in several structural and functional changes in the arterial vasculature. Over time, the arteries stiffen with the fracturing of the elastic lamella and intimal hyperplasia that is seen in the aorta. The stiffened arteries have decreased capacitance and limited recoil, with a subsequent difficulty to accommodate volume changes throughout the cardiac cycle. So systolic and diastolic increase in age. However, after the age of 60 years, the central arterial stiffness predominates. So as a result, the systolic BP continues to rise while the diastolic BP declines. This results in isolated systolic hypertension and a widened pulse pressure. This later increases with age independently of mean BP or any other determined factors. Then Sasaki et al. Have shown the NT-proNP, that is the natriuretic, that is pro-brain natriuretic peptide concentrations. This is maybe a marker of not only a ventricular dysfunction, but also arterial stiffness in the older population with cardiovascular disease. Then the natriuretic peptide, pro-brain natriuretic peptide, was positively associated with systolic BP, whereas a U-shaped association was found between diastolic blood pressure and NT-proBNP. So the hemodynamic mechanical changes, they alter wave reflections, causing a reduction in aortic elasticity, as well as loss of recoil in diastole, increase in pulse pressure, pulse wave velocity, arterial structure cause an increase in reflected pressure wave, added to forward pressure waves in the ascending aorta that further augments the central systolic BP. So there is also, we all know, there is a vascular endothelial dysfunction. There is also the decline of plasma aldosterone levels. So because of the nitric oxide bioavailability is descending. Then what is orthostatic hypertension? There is a reduced baroreflex sensitivity, that is arterial complex loss, that is orthostatic hypertension. Systolic BP, we all know, that is 20 millimeter mercury less, diastolic 10 millimeter. Orthostatic hypertension, that is a prevalence, carries 18% in older adults, associated with the increased falls and cerebrovascular effects. Then the Welbus et al. Showed that beta blockers were associated with the increased likelihood of developing orthostatic hypertension, the point to be noted. The older adults rely on increased cardiac output due to increased heart rate as opposed to changes in their stiff arteries to achieve postural homeostasis. There is also evidence orthostatic hypertension is associated with cerebrovascular events. There is also a clinical target that is less than 120 was not associated with a significant increase in orthostatic hypertension. So another important point, postprandial hypertension. This is in geriatric patients in an under-recognized cause of syncope. It is an under-recognized cause. The mechanism is unclear, but it appears to be related to reduced sympathetic response to a meal. Ambulatory BP monitoring and symptoms can give a diagnosis. The patient can be advised to increase water intake before eating or substituting 6 smaller meals daily for 3 larger meals that will prevent the postprandial hypertension. The elders and postprandial, older adults have an increased frequency of postprandial hypertension. Patients with heart failure, syncope, Parkinson's disease, end-stage renal disease on dialysis, autonomic dysfunction can have postprandial hypertension. Frail older adults and postprandial hypertension increase their postprandial BP and heart rate when walking. And aging and kidney, there is always a relationship. Aging changes in the kidney, increased salt sensitivity due to a decline in the activity of sodium, potassium, calcium, adenosine triphosphate pumps that prompts vasoconstriction and vascular resistance. Hypertension in the elderly is also associated with increased risk of ischemic and hemorrhagic strokes, vascular dementia, Alzheimer's disease, coronary artery disease, and other events. Atrial fibrillation, we all know, normal, regular, coordinated, sequential rhythm of atria is lost, that is atrial fibrillation. Chronic kidney disease and retinal diseases. The diagnosis of hypertension requires measurement BP in the proper environment, optimum conditions. It requires the patient must be relaxed in a chair at least 5 minutes, we all know, arm resting. In order to establish diagnosis, 2 readings of elevated on 2 at least occasions needed. White coat BP is more common among elderly patients, possibly related to increasing arterial stiffness. Thus, ambulatory or cutoff office blood pressure readings is important in a subgroup of patients with mildly elevated in-office BP readings. This is the steps to measure accurate BP. We must rest back and also the legs on the foot, and we should not talk. We should not have any coffee or alcohol, nothing. It should not be tied over the cloths. These are all the important things we must note. So these are all the 7 tips. My mnemonics: keep bladder cuff to be tied over bare arm and not over clothes. BP, it adds 10 to 40. Keep bladder urine to be empty. Full bladder adds 10 to 15 millimeter. Keep arm supported on table at heart level. Unsupported adds 10 millimeter. Keep back supported on chair. Unsupported 5 to 10 millimeter mercury. Keep legs uncrossed, if not adds 2 to 8 millimeter of mercury. Keep supported your legs on floor. Unsupported adds 5 to 10 millimeter. Keep yourself free, more than no conversation during BP recording. So selection of cuff sizes, very important. Small, adult, large, extra large. 20 to 26 centimeter, 12 to 22 small adult. 27 to 37, 16 into 30 adult. 35 to 44, 16 into 36 large adult. 45 to 50, 16 into 42. Very important is the ideal cuff bladder length is more than 80% of the patient's arm. 80 or more than 80% of patient's arm circumference. Ideal cuff bladder width should be 40 or more than 40% of patient's arm circumference. So these are all the ACC ESH ratings. This we have already highlighted. That is 130/80. That is European Society 140/90. So high BP is primarily asymptomatic. Structured community program play an important role, and it is effective in diagnosis. Patients unaware they have got hypertension. These are all the current evidence. Treatment of isolated systemic systolic hypertension. That is a step study. Another is Hypertension trial, and all those things I have already highlighted. So this is a sprint trial. That is the BP systolic, that is less than 120, aged over 75. So this convincing evidence, in spite of that, the benefit of antihypertensive treatment in older adults with hypertension, the optimal BP target has remained unclear in the population. This mostly derives from the higher vulnerability of older adults develop complications from antihypertensives such as orthostasis, falls, renal dysfunction due to the burden of comorbidities and advanced age and frailty. Already I have highlighted all the trials. This is the HIVET and SPRINT trial. Again, they are all incorporated in 2017 Canadian guidelines that propose a target of systolic blood pressure less than 120 for all individuals aged over 75 years. So this is 2018 and 2017 American College of Physicians, Family Physicians guidelines. So they all proposed less than 140/90 for individuals older than 65 years. 2017 American College, American Association and Family Physicians less than 150/90. So on these different recommendations regarding the target BP in older adults, it seems clear that there is still debate on optimal BP target. So every guideline changes from one year to other one. This is the 8th National Committee, that is JNC 80, 140/90 for people aged about 60 years. That is 8th Joint National Committee. So recommend the physicians to critically assess the evidence as there are strength and weakness of discussions on BP targets in older adults. So choose the target blood pressure in older adults and with hypertension requires discussion between physician and the patient that is taking into consideration several factors: burden of comorbidity, life expectancy, clinical judgment, and patient's preference. This is again same sprint and HIVET study. So they all suggest the BP reduction in the frail individuals may be rather harmful. So this is 40 to 69 years. This is 20 millimeter systolic and 10 millimeter. That is, increase of diastolic is associated with more than twofold difference in stroke-related death, that is due to ischemic heart disease, that is from other vascular etiologies. And also differences were about half as extremes between age 80 to 89 years. So it's all found out by National Health and Nutritional Examination Survey, SHEP trial, and HIVET trial. So sprint and most guidelines, they all, that is 140 or 90 less than with chronic kidney disease. So these are all the things which is highlighted in HIVET and the sprint trial. So this is the chronological order of, this is just to highlight, this is the tabular column. This is the pivotal trials of hypertension, that is very important, which we have already told. So the challenges in cardiac, that is geriatric cardiology, that is the overall medical, physical, social, and mental characteristic, very important. There is definitely a personalized medicine. So physicians needs to alter, current practice to alter pharmacokinetics and pharmacodynamics in aging and mindful issues. 1. Cognitive impairment, knowing, understanding things, competing medical health problems, polypharmacy, orthostatic hypertension, falls, gait speed, medication cost, side effects, incontinence, fatigue, visual, auditory limitations, social support, caretaker availability, and frailty. So it is a misconception to assume that advanced age precludes aggressive interventions. It is vital to rule out pseudo-hypertension, masked hypertension, situational hypertension, and exclude secondary causes in case of resistant hypertension. So the non-pharmacological therapy is very important. Regular physical activity, weight control, smoking, stress, avoidance of excessive alcohol intake, the healthy dietary approach to stop hypertension, very important. DASH diet, low carbohydrate, vegetarian, plant-based Mediterranean, as well as low sodium, potassium supplementation, 1500 to 2000 milligram, calcium, magnesium supplements, consumption of probiotics, fiber, flaxseed, increased protein intake, consumption of garlic, dark chocolate, tea, coffee, and fish oil. So behavior therapy is also very important. Sleep apnea, renal artery stenosis, prostatism, primary aldosteronism should also be addressed. What is behavior therapy? Transcendental medication, yoga, Tai Chi, biofeed have known effect in decreasing BP. We all know the omnious 8 presentation of yoga, yama, niyama, asana, pranayama, pratyahara, dharana, dhyana, and samadhi. So we must review the patients, and recreational drugs and caffeine, tea, and herbal supplements also be required. So 1000 milligram, we all know that is the reduction in sodium intake. DASH eating plan is also very important. So physical activity, very important, effective. That is we have to be 65. That is that 90 to 150. That is we must appropriately per week. That is at least 30 minutes, 5 days in a week, or 20 minutes per day, or in 7 days. That is dynamic resistance 90 to 150, or isometric resistance 3 sessions per week, or 4 to 2 minutes of hand grip, 1 minute rest, 30 to 40% of maximum voluntary contraction. So older adults at any sub-maximal exercise load will exert a high maximal capacity and effort than younger individuals. They may benefit of experienced fitness trainers to define optimal frequency, intensity, and duration of each type of exercise. FIT principle, frequency, intensity, and type and timing of exercise. This is again the American Sports College of Sports Medicine. Again, this is what I have told. Frequency, intensity, type, and timing of exercise, 150 minutes per week. Again, home BP monitoring, very important. This is very much highlighted by mentor, Dr. Muruganathan, the past governor He is the director of Old Medical Academy and also editor of MediBeats. He has been stressing the importance of home BP monitoring for a long time. In fact, he has imposed BP monitoring in shops, vegetable markets, and public places to propagate public awareness. People are aware of self-monitoring of blood glucose, but not self-monitoring of BP. That is why he insists the significance of self-monitoring of BP. So the pharmacological interventions, we all know, that is the hexagonal approach. A, B, C, D, E, F. A, ACE inhibitors, B for blockers, C, calcium channel blockers, D, diuretics, D, exercise and diet, and F, find out the cause for resistant hypertension. So this is my mnemonics: ACE inhibitors, angiotensin receptor blockers. Blockers, alpha blockers, beta blockers. Diuretics, thiazide diuretics, thiazide-like diuretics. Exercise, lifestyle modification, find out the cause for resistant drugs, endocrine, renal coarctation. This is the hexagonal approach. So isolated hypertension, single pill combination is ideal. If necessary, polypill combination. So we must initiate any drug, renal function assess, GFR, BP-related reactions, hypokalemia, important side effect of diuretics. So we must be cognizant of treatment-related side effects, and accordingly we must do it. So the future allocation, key component of managing elderly is to address lifestyle modification, the elderly population, to prevent hypertension with aging. So there is a component just related to aging of all the tissues. There is also a critical behavior component, especially reducing obesity, incidence of diabetes, tobacco use, alcohol consumption, hypertension, young, again, telemedicine, very new clinical trial evaluating drugs. Fimasortan is gaining momentum. And also the invasive strategies, that is renal denervation. So this is my mnemonics. Hypertension is an abnormal elevation of blood pressure due to increase in cardiac output and peripheral vascular resistance. H. Y, younger to old age group. P for primary, essential high blood pressure, pregnancy hypertension, postural hypotension to be avoided during therapy. Pulse pressure, what is it? The difference between systolic and diastolic blood pressure that is frequently increased in older people with hypertension. This can mean the systolic pressure is abnormally high, but diastolic pressure may be normal or low, and that is a condition termed isolated systolic hypertension. E for exercise, lifestyle modification, diet dash, or risk factor for coronary artery disease, stroke, heart failure, atrial fibrillation, peripheral vascular disease, vision loss, chronic kidney disease, and dementia. So another R for resistant hypertension. What are the types? We all know: white coat, BP, reverse white coat, that is masked hypertension. That is home BP, hypertension under control, hypertension no control. E for end organ damage, E for E, just remember, hypertension emergency. No end organ damage, hypertension urgency. Normotension is to be achieved. S for secondary high blood pressure, I initiate therapy once diagnosed, lifestyle modification, drugs. Oral drugs preferred, emergency situation parenteral, and nocturnal dipping, 4 types of dipping: dippers, non-dippers, extreme dippers, reverse dippers. These are the types. So let me conclude: the increasing burden of hypertension in the growing population of elderly patients, while lifestyle changes have potential to mitigate this, adoption of healthy practices have been lagging in many countries. We must educate, awareness program in community centers, place of worship, temples, churches, synagogues, mosques, business centers, barbershop initiatives will continue to have impact. So we must screen blood pressure elevation, improve access to care, adopt guideline-driven management are keys to reducing the impact of hypertension in our elderly patients. Further research is needed in the population. That is, most clinical trials include a small proportion of persons who are 85 years old. So these trials can help solidify a current recommendation to use, that is 130/80 after lifestyle intervention, as a threshold for initiation of therapy. Less than 130/80 are the target of therapy. Thank you very much for the patience hearing. I hope I have finished hypertension the elderly. elderly. Thank you very much for the patient listening. Good evening, Dr. Anupam Prakash.
Good evening, sir. Good evening, everybody.
Thank you. Thank you. You are the next speaker.
Yes. Well, I'm just starting to share. Thank you so much, Chairpersons. Dr. Rajshekhar has already given a very elaborate discussion on hypertension. And the next is diabetes. To be sandwiched between hypertension and diabetes is not an easy task. But yes, I think with hypertension and diabetes, I will be dealing about adrenal insufficiency. And as the topic has been given to me, it is an underestimated entity. So I will take you in the next 10-15 minutes on this journey of adrenal insufficiency. Are my slides visible? All be in charge, please.
Yes, yes, visible.
So this is the gland which is, as an MBBS, it is taught gland of fight, flight, and fear. And yes, it is important. And I will take you to what happens when this gland is hypofunctioning or the responses are actually less. So why it is actually underestimated during the course of the talk, it will be very clear, and that is my concluding slide also. But despite the underestimation, despite the low prevalence, the incidence and prevalence have been rising over the last few decades. And this is important. And although you will understand the prevalence is 117 per billion, which is less than 1% of the population that we have. So that is why actually the prevalence is so low that the suspicion is not high. This is with hypertension and diabetes, as Dr. Rajshekhar just said, and Dr. Sunil Gupta will be talking. So this is the problem, that with such a low prevalence, the incidence which is rising at about 1.8% per year is still, it is not so much. So this PI stands for the adrenal insufficiency, the primary adrenal insufficiency. Just like essential hypertension, it is the primary adrenal gland which is diseased in this case, and that is what we are talking about. The annual incidence is somewhere about 0.44 to 0.62 per 100,000. So it is a very low prevalence which is there, incidence is there, and the prevalence also is so low. So that is why actually it escapes our eyes, it escapes our mind. But the importance is there, and once you diagnose it, you probably have a definitive treatment. That is the importance. Now, the male to female ratio is 1:3.5. The females are more affected, and that is probably something to do because of the etiology. So autoimmune diseases, the autoimmune adrenalitis is one of the commonest causes of hypoadrenalism or adrenal insufficiency. And similarly, even tuberculosis in our country, which is a very common cause of adrenal insufficiency, is again more seen in ladies in our community, in our country, because they don't get to go out of the house, and we are still 74% of the population is still remote or rural areas or semi-urban areas in our country. The age of onset, again conforming to the autoimmune adrenalitis that is there, the age is 30 to 50 years, which is usual. So this is the general epidemiology, and we understand that this is going to be a disease which has to be very high index of suspicion, then only you will be able to diagnose it. So the common causes, the two most common causes are autoimmune adrenalitis and tuberculosis as part of infection. But yes, we have a whole lot of other granulomatous diseases. I will come to the next slide. But at times there could be bilateral infarction, metastasis, yes, very common at times, because this is a disaster presentation that we have. Hemorrhages, adrenalectomy, which obviously would be there when we know the patient has had bilateral adrenalectomy. You understand that the patient will be prone to primary adrenal insufficiency. And at times genetic syndromes, we come across cases of congenital adrenal hyperplasia and adrenoleukodystrophy. And importantly, if you have adrenalitis or autoimmune adrenalitis, you should think of other disorders and vice versa. If you have autoimmune disorders, and patient comes to you, thyroid disease, type 1 diabetes, pernicious anemia, primary ovarian insufficiency, and autoimmune AEPC, endocrine polyglandular syndromes, then you should always think of autoimmune adenitis if the patient has some symptom complex, which I will just allude to a couple of slides later. So this is the whole spectrum of etiology of primary adrenal insufficiency. So here you can see autoimmune damage could be isolated, or it could be part of autoimmune polyglandular syndrome, type 1, type 2. Infections apart from tuberculosis, which is very, very common in our country, and tuberculous adrenalitis is also common. Systemic fungal infections, Waterhouse-Friderichsen syndrome, when you have altered mental status, hypotension, fever, so you have hemorrhages in the adrenal. Septic shock, yes, very common. We have patients who come to us with hypotension as part of it. And opportunistic infection, the whole lot of fungal infections you have. Again, infiltrative diseases, you should understand sarcoidosis, amyloidosis, hemochromatosis, and metastasis as part of primary somewhere else like lung, breasts, or kidneys. Similarly, adrenal hemorrhage, coagulation disorders. So this is important. A patient who comes to you on anticoagulant treatment, if that patient develops hypotension, it could be, yes, bleed, which is very common, but at times it could be primary adrenal insufficiency. So bleed into the adrenals could also present to you with hypotension. Similarly, you have drugs, and it is important, apart from the traditional drugs which inhibit the cytochrome P50, or those who are which impair steroidogenesis, like antifungals like ketoconazole and fluconazole. Now there are a new class of drugs like the immune checkpoint inhibitors, sorry for that, immune checkpoint inhibitors, the monoclonal antibodies. So you have the nivolumab and pembrolizumab, which are used for treating leukemias, which actually can trigger immune reactions and contribute to the autoimmune adrenalitis. So this is important. Drug-induced adrenal inflammation can also contribute to primary adrenal insufficiency. Apart from that, yes, adrenoleukin dystrophy we have. So this is an X-linked recessive young man afflicted disorder, and importantly, this will be negative for antibodies to 21-hydroxylase. So apart from the primary adrenal insufficiency, we also have a secondary or tertiary adrenal insufficiency. So as the name goes, secondary is when the pituitary is diseased, tertiary is when the hypothalamus is diseased. So these are also known as central adrenal insufficiency. So there is a group of peripheral adrenal, the primary adrenal insufficiency where the adrenal is diseased, and then you have secondary and tertiary adrenal insufficiency where you have the hypothalamic and the pituitary axis, which is actually abnormal. So there could be infiltrative disorders, there could be tumors, there could be primary ACTH deficiency and hypophysitis. Very common in our country could be Sheehan syndrome, where pituitary necrosis can be there, and the patients come to us where there is actually postpartum infarction of the pituitary. So this is a very common entity. We have encountered patients, and unless until you ask the patient will come to you with a secondary amenorrhea. Postpartum, the patient would never start menstruating, and this is a very important cause. Patient would be very pale and anemic at times, and patient will be listless and hypotensive. Blood sugars may also be, hypoglycemia also may be there. So this is a characteristic secondary adrenal insufficiency, and we do find one or these patients would come to you once in a blue moon. So maybe once in a couple of months, once in 6 months, but yes, a high index of suspicion because you can treat these patients. Once you replenish the hormones in a patient of Sheehan syndrome, this patient would lead a normal life. So that is the importance. Tertiary, yes, the commonest is tertiary adrenal insufficiency, which is actually promoted by high-dose glucocorticoid suppression. And at times this could be life-threatening. If in these patients, you actually stop glucocorticoid suddenly, these patients can actually land into severe adrenal insufficiency. At times repressing lesions, yes, but these are not common. At times opioid addicts can also come. So these are uncommon causes, but yes, I have already highlighted the common causes which are there. Now, why actually is missed? It is not only because of the rarity of the disorder or the rarity of the adrenal involvement in various diseases, but the symptom profile also is very, very, I would say, non-specific. So we all understand. So fatigue and lethargy, which may be there, which many patients had during COVID also. Loss of appetite, weight loss. Again, we understand we are having tuberculosis as a very common system, let's say a disease in our patients. And it is a very non-specific symptom. Even leukemias, lymphomas, malignancies, everything can be attributable. Even depression, loss of appetite, weight loss may be seen in these patients. Nausea, vomiting, abdominal pain, again another group of gastrointestinal symptoms. Melanoderma, this actually will be visible or available if you seek for in patients, if these patients have primary adrenal insufficiency, not in the central adrenal insufficiency, but yes, primary adrenal insufficiency, they will find hyperpigmentation. At times, dizziness, orthostatic hypotension, yes, and salt craving, hyponatremia, hyperkalemia. These are attributable to the aldosterone or the aldosterone component, mineralocorticoid component of the adrenal hormone, which is actually deficient. And at times, these patients will come to you with acute adrenal crisis. So any precipitating factor can actually, any stress, because they do not have the adrenal reserve, the glucocorticoid reserve to actually take them out or bail them out from any crisis situation. So even a minor surgical procedure, even minor infections can precipitate acute adrenal crisis. Now, the important thing is they are all non-specific, you all understand, and more than 50% of them would either go to general physicians or to patients and wrongly diagnosed as gastrointestinal disease or psychiatric disorder. So you can understand the first two symptoms are very vague. And at times these patients would come walking, would complain of aches and pains and lethargy and fatigue, and the endocrine disorder would be missed. And similarly, patients who have nausea, vomiting, abdominal pain, they may go to a gastroenterologist or to a general physician or to a general practitioner, but still, unless until you have a high index of suspicion, these patients would just be missed. So they are actually more than 50% had at least 3 consultations. That is what the record says. And so there is a fair amount of time. At times, patient delay in diagnosis could be as long as 5 years. We have seen patients of Shihans presenting to us as late as 10 to 15 years. So they have not been diagnosed. So that is the ominous thing that is there with this. And that is the time that this disease actually goes on. And actually, that is why it is under-manifested, underestimated, and a problem for all the physicians to diagnose. Additional features could be there like hypercalcemia, mild normocytic normochromic anemia, lymphocytosis, eosinophilia, hypoglycemia. Yes, very common. These patients at times can go into recurrent episodes of hypoglycemia. And increased viral infections also, they are predisposed because there is reduced natural killer cell cytotoxicity. So there is an immune deficiency also because of the glucocorticoid deficiency, and these patients will be predisposed to increased viral infections, and they can come to you. In fact, these could be the reasons for precipitating an acute adrenal crisis. And yes, they may have low libido and low reduced energy levels, which is also important for us to treat. Excessive pigmentation I have already dealt, because that is in primary adrenal insufficiency because of the excess ACTH which is there, or CRH which is there, and you can have exposure. Mucous membrane especially you should see, and in which areas you can have hyperpigmentation. Yes, this I have already mentioned. Now, this is the 4 stages which you actually say. So at times, the earliest stage, stage 1, is very, very difficult to diagnose because it can manifest with just mild impairment of aldosterone. It is believed that the zona glomerulosa, which produces aldosterone, is damaged earlier, and because there are some intracellular or in the vicinity of the zona fasciculata, you have some steroids which are already there. So they prevent the immune-mediated damage to the zona fasciculosa, and zona glomerulosa is the earliest to get damaged. And so aldosterone levels, the orange bar, actually gets reduced in the preclinical to stage 1. And this is one of the earliest manifestations that you have. And correspondingly, you see the renin levels, the gray bar actually starts rising. In stage 1 to 2, you have deterioration in the peak cortisol level. And in stage 2, the basal cortisol levels are also reduced, and you have rise in ACTH values. And so that is the stage where you should actually consider glucocorticoid substitution. And yes, a high index of suspicion will diagnose at stage 2 also, at stage 2 onwards. So that is what is very, very important for all of us to realize. And gradually, stage 2, 3, 4, you will find that the basal cortisol goes down and ACTH levels keep on increasing. So this is important. And for diagnosis, in case where you have a very severe adrenal insufficiency, a serum cortisol morning level, we understand that your morning serum cortisol is higher, and during the day, the cortisol levels actually reduce. That may be actually the reason why many people feel a little fatigued or lower energy as the day passes by. But yes, that is normal. But if the morning serum cortisol is low, coupled with ACTH values which are more than twice normal, this is a very high index of suspicion that yes, the patient may be having an adrenal insufficiency. So if you go further, a baseline cortisol any time during the day, if it is less than 55 nanomole per liter, it is going to predict that yes, this patient will be having a low response to CRH or corticotropin. So we should, ideally the diagnostic test is corticotropin stimulation test, and you give, there are two preparations which are there. So you can give either. So sample ideally for primary adrenal insufficiency should be at 30 minutes. And this will diagnose 95% of the primary adrenal insufficiency. For central adrenal insufficiency, it is said that yes, you should diagnose at 60 minutes. You can take a sample at 60 minutes. It is more diagnostic accuracy is there. But there is you may have to have a combination or 30 minutes or 60 minutes, both sampling may be required. But yes, for primary adrenal insufficiency, it is believed that 30 minutes would be very, it can be done. And corticotropin stimulation test can be done any time of the day because the adrenal is already suppressed and you can get a rhythm. It is not suppressed and there is no relation to circadian rhythm. But yes, if you do it early morning, you would avoid overdiagnosis because as I just discussed, as during health, it is actually the cortisol levels decline during the day. So you will not pick up those patients, those who are healthy. So, but otherwise, corticotropin stimulation test can be performed any time of the day, and you would invariably get a result. So this is the flow chart. So I have taken from an author. It is a very nice flow chart, and I thought that this would be the very elaborate. Rather, so this I have discussed the green bar on the top. If you have morning serum cortisol which is less than 140 with a ACTH which is more than 2 folds, this suggests that yes, this patient is likely to have adrenal insufficiency. When you perform concentropin test, the corticotropin stimulation test, so you give 250 micrograms. There are two preparations I said, but both of them have to be given 250 micrograms. So whether it is Synaxin or other, you can give 250 microgram IV and get after 30 minutes a serum cortisol level. Now, there is a problem with immunoassays. Immunoassays, the cutoffs have to be less than 500 nanomole per liter. But yes, if you have the liquid chromatography, mass spectrophotometry assay, then you can pick up early levels also. So less than 400 or 455 milliliter nanomole per liter. So that will clinch you the positive diagnosis. If yes, you get low, then definitely it is a adrenal insufficiency. Then you need to find out the cause. If the 21 hydroxylase antibodies are positive, it is autoimmune primary adrenal insufficiency. If the aldosterone is also low, then yes, a low aldosterone with a high plasma renin activity indicates that it is not only glucocorticoid but also mineralocorticoid deficiency. And if the adrenal antibodies, the 21 hydroxylase antibodies are negative, then definitely you should go ahead with a CT and see for in young adult males that they may be having a adrenoleukodystrophy which may be there. Otherwise, it is autoimmune adrenal insufficiency. And in our patients, if you get a CT scan done and you find necrosis, then it is most likely a tubercular disease. Now, coming to the management, the last part. So I will stick to time only. The replacement, there it is a three-pronged management that is to be there. The first is management of hydrocortisone that you have to supplement the cortisol. So you need to give 15 to 25 milligram. Now, this is important to understand that the requirement of adrenal insufficiency, these patients have a very low requirement. You should try to keep them between 15 to 20 milligram of hydrocortisone, maybe slightly lower side also, because that is sufficient for the adrenal, the high cortisol replacement in these patients. A higher doses may actually induce some oppression, may have metabolic derangements, may have what Dr. Shekhar was talking about, hypertension, and what the next speaker will talk about, diabetes also. So some dysglycemia, bone mineral density, all those things would actually be hampered when you give a higher dose of hydrocortisone. So 15 to 20 usually, or maybe 12.5 would be sufficient for these patients. But if preferably give them in divided doses, a higher dose in the morning and a lower dose in the evening, because that is what these actually the supplementation, the body's endogenous rhythm is. For monitoring signs and symptoms of over and under replacement, so you don't need to do an ACTH measurement because these patients will have a negative feedback, and that is actually disrupted because of a chronic adrenal insufficiency. So when you check for signs and symptoms, you check for replacement with body weight improvement, blood pressure, and the hyperpigmentation, the bone mineral density levels, and the energy levels. So if the patient starts improving, then yes, you understand that the improvement is there and you can continue with that dose. Now, this is just, we all understand hydrocortisone 20 milligram equivalent to prednisone 5 milligram and methylprednisone 4 milligram and dexamethasone 0.75 milligram along with the anti-inflammatory activity which is there. So this is a replacement dose. So 20 milligram would just 5 milligram prednisone or dexa 0.75 that you can actually give these patients. This is the second pillar. If there is concomitant adrenocortical deficiency, you need to give fludrocortisone as a single morning dose and ask the patient to have salt. This is important. And over replacement or under replacement, you can manage with clinical signs again. So the monitoring for adrenal insufficiency patients when you start them on replacement therapy is based upon clinical signs and not on biochemical improvement, because biochemical improvement may take a long time. So this is important. And the third pillar is patient education, because you don't want your patients to actually go into acute adrenal crisis. So the patient education is very important. Any patient who has an intercurrent illness, you tell these patients, primary adrenal insufficiency patients, they should supplement. So they should take an additional dose stat and double the dose for the next 5 days. If they have concomitant fever, additional dose stat and triple the daily dose for the next 5 days. This is very important, 3 to 5 days, that is important. You need to actually tide over that stress. If the stress is longer, then you give for a longer period. So this is very, very important. And teach these patients to administer, or their relations to administer IM hydrocortisone. If they cannot give IM hydrocortisone, they should give subcutaneous, because subcutaneous, the studies have shown that the subcutaneous hydrocortisone injection takes only 11 minutes longer than the intramuscular injection. So it is important, if the patient can take it like that, at least the patient will take a longer time to reach hospital. This drug will start acting immediately. So this is important. These patients have to understand they should rest during their sick days, take medications extra, supplement themselves so that they prevent the acute adrenal crisis in these patients. So this is my last slide. So I would say the topic given to me was, it is underestimated, but more than underestimated, it is uncommon, definitely. It is also under suspected. It is underdiagnosed because our tools are not easily available. Our awareness levels are less. It is often missed also, unless until the patient is having, I would say, severe deficiency. It is untreated, but yes, if you treat it, it is very productive, and the patients do have a very good improvement in their quality of life and longevity also. And definitely the topic to me, given to me was absolutely right. It is underestimated also. Well, thank you. Thank you so much.
Thank you,
Dr.
Dr.
Sunil Gupta,
Thank
sir.
you. Thank you,
Thank you,
Dr.
madam.
Prakash. Very nice to present it. Underestimated, uncommon, very rarely presenting. Thank you very much.
Thank you, madam. Thank you, Dr. Ashika, sir.
Congratulations, Dr. Anupam.
Thank you so much, sir.
Good.
I have been sandwiched between hypertension and diabetes, between Dr. Ashika and you.
Yeah. And that too with
Thank you, madam. Thank you so much.
Not to diabetes, to pregnancy.
No, we will talk about what physicians must know about diabetes and pregnancy. Most of the people are more concentrating on the diabetes of the young and diabetes of the children, but most of the time it is really neglected in the parts of the patients who are pregnant. So we should focus on the patients who are having diabetes with pregnancy. And this topic will be given by the Dr. Sunil Gupta. Sir, welcome to the topic. He is a diabetologist, CEO and MD, Sunil's Diabetes Care and Research Center Private Limited, Nagpur. He is the National President of Diabetes in Pregnancy Study Group India in 2021 and 22. He is the National Treasurer of RSSDY Headquarters. He has been awarded with 19 orations and 6 international and 6 national fellowships. He is very famous I have already heard his talk before. Now, most welcome, sir, Sunil sir. And you will start your talk.
Yeah, thank you very much. And I'll just take maybe 10 seconds to upload my slides.
Okay, sir, no problem.
Hopefully they are visible. Are the slides visible?
Yes, sir.
Hope they are full screen.
Yes, sir.
Okay, good. So thank you very much once again for a wonderful, and it was a wonderful feast from Anupam and the senior person, Dr. Amtan, for the hypertension. What a physician must know about diabetes and pregnancy. And I'm thankful to the whole team of APICON ODISHA 2022 under the leadership of my very close, thick friend, family friend, Dr. Jayant Panda. And of course, my senior teachers from Orissa, Dr. A.K. Das, Dr. Siddharth Das, and Dr. Nihar Mohanty. Thank you very much for this honor and opportunity to interact with you. There's no conflict of interest for this particular session. I'm going to cover this talk on some slides on introduction. And we have tried to give an important messages rather than the theoretical discussion on diabetes and pregnancy. And we'll try to address the issues of screening, diagnosis, management, and carry home message. The first question which every physician should know is, why should we bother about hyperglycemia and pregnancy? Why should we treat hyperglycemia and pregnancy? David Barker, who said that what he has conceptualized is the body's susceptibility to lifestyle disease or diseases actually was programmed intrauterine. And it is the intrauterine programming which is important for the fetus. I'm sorry. Yeah. Okay. There's some missing things here. Let me just check. Are you able to see the slides? Because something is missing.
Yes, sir, they are visible.
Yeah. So it is being said that it is the intrauterine programming which is important, that the intrauterine environment, if it is hyperglycemic, it has its impact on the fetal it causes epigenetic changes in the fetus, and that is responsible for development of adult diseases in these fetuses born to these mothers. And that is why that's a concept of fetal origin of adult disease. And that is why Professor Shaya, the founder of DIPSI, says focus on fetus for the future. So if you want to save future generations, we'll have to address this issue from now itself. Why it is relevant? There is high risk of maternal and the perinatal morbidity and mortality and the poor pregnancy outcome. So if you don't control blood glucose well, there is high risk of having neonatal issues, missed abortions, stillbirth, macrosomia, IUGRs, hydramnias, oligohydramnias, and lot many other issues, neonatal hypoglycemia. I'm not going to go in detail of it, but it certainly, if you don't control metabolic environment or hyperglycemia in pregnancy, you're likely to have effects on the fetal outcome, as well as there can be issue of preeclampsia and hypertension and other issues in the mothers. Then the offspring of GDM mother, they are at high risk of having metabolic problem in the adult life, including diabetes. And the mother who had past history of GDM, they are likely to have diabetes as well as other cardiovascular disease in their subsequent life. So basically, why should we be treating hyperglycemic pregnancies? Not only for the good neonatal outcome, but also to save future generations, the baby as well as the mother. So there are two generations who are at risk, the mother and her offspring. And that is why hyperglycemia in pregnancy should be addressed very aggressively across this part of the continent. Now, it is, if you just see this, why in 1 in 6 live births, almost 17%, are the women who have some form of hyperglycemia in pregnancy. Recent atlas of IDF says almost every 4th woman in Southeast Asia, they have some form of hyperglycemia in pregnancy. Maybe 16% of them pre-gestational diabetes, and around 85% of them are gestational diabetes. Very important here for us as a clinician is the age of onset of diabetes and pre-diabetes is declining, and the age of childbearing is increasing. And that is one of the mismatch. And we are getting more and more number of patients, women coming to you with overweight, obesity, having some of the issues with infertility, as well as having diabetes. So it is obesity in the young women, polycystic ovarian disease, and pre-existing young women with diabetes. They're all aspiring for pregnancy, and they come to you with metabolic derangement, and we need to be mentally prepared to treat them. And of course, we should be aggressive enough to have take care of them. And this is a big challenge which we are going to face in future. To define gestational diabetes, is being diagnosed in the second or the third trimester commonly. That was not clearly the overt diabetes or pre-existing diabetes. And to make this simplify, FIGO, the Federation of Obstetrics and Gynec, have actually classified it little in a simplified way, that you have an umbrella term called as hyperglycemia in pregnancy, which is again divided into two: the hyperglycemia in pregnancy and gestational diabetes. Gestational diabetes appears typically in pregnancy, disappears after delivery, and the dip is diabetes in pregnancy, where you have pre-existing type 1 and type 2 diabetes becoming pregnant, or few of the diabetics who are diagnosed during pregnancy, but actually clinically they are pre-existing type 2, rarely even type 1. So a physician must know why should we treat it, that we have learned. Now, who should be screened for hyperglycemia in pregnancy in India? So Indian women are around 11-fold increased risk of developing glucose intolerance during pregnancy, and we are at the high ethnic group population. And that is why all women who are coming to the ANC clinic, irrespective whether they have symptoms, whether they are from the high risk group or a low risk group, whether they are of age of 21, 22, non-obese, no family history, and maybe primary, but still everyone should be screened, and they are the Government of India guidelines. Now, how to screen these women? We have Government of India guidelines, which were published in 2014, have been again published in 2018, and they said that there's a single step test which can be utilized for diagnosis as well as screening. Just give 75 grams of glucose in around 300 ml of water, and it can be given either in fasting state or in non-fasting state whenever a patient comes to you, and take 2 hour blood glucose or plasma glucose. If it is more than 140, diagnosis GDM. If it is between 120 to 140, it is the DIPSI has in 2006 has recommended that it could be gestational glucose intolerance. Few of the country, they call it as mild GDM. Some of them, they call it as IGT in pregnancy, or different names are being used. But even any blood glucose above 120 should be taken as concern. But if someone comes to it more than 200, of course, every one of us know that it is pre-existing diabetes. Now, what are the glycemic targets? Once you're diagnosed, what are the glycemic targets? So it is almost now 30 years from now that we have there was a St. Vincent Declaration, which said that achieve a pregnancy outcome in diabetic women that approximates that of the non-diabetic women. And if you try to understand the glucose in normal pregnancy, which is non-diabetic pregnancy, the mean blood glucose never exceeds around 88, the 1 hour around 109, fasting around 70, and 2 hours around 100. And that is why if you want to achieve a blood glucose target, or try to achieve a blood have a glycemic target of as that of the non-diabetic women of the same age and same weeks of pregnancy, then we have to try to match these readings. And that is why a recommendation is that fasting should not exceed 90 and 2 hours should not exceed more than 120. Global recommendation also gives another matrix of 1 hour, which is less than 140. If you have maternal hyperglycemia, it will cause fetal hyperglycemia, placenta fetal hyperinsulinemia, and pancreatic hyperplasia. They are responsible to have adult onset disease. If you have maternal hypoglycemia, it will again cause fetal hypoglycemia, pancreatic hypoplasia, and that will also be a risk factor for adult onset diabetes. And that is why we should not be over treating and we should not be under treating. Now, what is the role of HbA1c and CGM? SMBG, self-monitoring of blood glucose or home blood glucose monitoring is, of course, is must. But we know that there is an increased RBC turnover, and HbA1c is slightly lower in normal pregnancy than in the normal non-diabetic non-pregnant women. Ideally, A1C should be less than 6 if it can be achieved without significant hypoglycemia. but targets can be relaxed to less than 7 if there is a risk of hypoglycemia, especially in type 1 diabetes. When used in addition to pre and postprandial SMBG, even CGM can also help you to achieve better glycemic control. But self-monitoring of blood glucose is basically a gold standard, and but CGM metrics are also being recommended. Now, what are these CGM metrics? HbA1c we should try to keep. I told you less than 6 is ideal. 6.5 is also acceptable. 7 is only in type 1 diabetes if you have increased risk of hypoglycemia. So now they have some CGM metrics which international body has recommended. The time in range should be kept between 63 to 140, and in type 1 diabetes it should be more than 70%. Below range less than 653 should be less than 4%. Time below range less than 54 should be less than 1%, and time above range of more than 140 should be less than 25. This is for type 1 diabetes. But if you have the, I'll just show you with the highlighter here. If you have the pre-existing the type 2 diabetes or gestational diabetes, you should try to achieve it 80%, not 70%. Now, how to achieve these targets? Medical nutrition therapy, exercise, oral drugs, and insulin, and of course the education. What is the role of metformin and sulfonylurea in pregnancy? Now, metformin, we have some gray zones. The fetal concentration of metformin, almost all drugs, whether it's metformin, glibenclamide, or any other drug, oral drugs, they cross the placenta. Insulin does not cross the placenta. I repeat, oral drugs, metformin, glibenclamide, acarbose, they cross the placenta, but the insulin does not cross the placenta. The fetal concentration of metformin are equal to the maternal, and the metformin can inhibits the growth, suppress the mitochondrial respiration, have epigenetic modification, the gene expression. It may mimic the fetal nutrient restriction and alter the postnatal gluconeogenic response, because both the placenta and the fetus express metformin transporters and exhibit high mitochondrial activity. These properties, there is an important question of the developmental programming of metabolic disease in the offspring. But this was again a thought and a hypothesis. We have a good now clinical trial, which is MITI trial, type 2 diabetes, and they have been given metformin from preconception till delivery to all type 2 diabetes, and the other arm was on insulin. And they have found that the only concern was a small for gestational age, and rest of all other things were quite acceptable in the insulin versus metformin group. There are also data coming from the polycystic ovarian disease group where metformin was used, and the outcome was found to be as that of the insulin group, and they have been acceptable in PCO group. But the only recommendation is in PCO group, after you achieve a pregnancy, was the infertility is over, in 12 weeks period, after in 13th weeks, you can withdraw metformin. There is no additional benefit of metformin continuation after 12 weeks of pregnancy. What does the government of India says? Metformin and insulin is acceptable medical therapy after 20 weeks. Insulin can be given anytime in pregnancy, and metformin to be given after 20 weeks. The European guideline recently in February 2022 has come out with a recommendation that metformin can be used from preconception till delivery after the trial results of MITI trial. What about sulfonylureas? Sulfonylurea also causes the placenta, especially glibenclamide here, and to a high level, and it may increase the risk of neonatal hypoglycemia, macrosomia, than insulin or metformin. And it has not shown any additional benefit. And unfortunately, we don't have a long-term safety data available. And that is why sulfonylurea is not being recommended by our bodies, but in other countries, it's being used. Now, the next question for a physician is, what are the absolute indications of insulin? Which insulin, when, how to start insulin? Their absolute indication, if you have very high HbA1c, ketonuria, ketosis, renal insufficiency, hepatic insufficiency, macrosomia, IUGR, hydramnias, deteriorating blood glucose control, on steroid therapy, insulin becomes an absolute indication. There are regular aspart and lispro, detemir, and NPH and premixed of all this is being approved. Faster aspart is again another insulin, which is again a good insulin, and that controls postprandial hyperglycemia better. Insulin in pre-existing type 2 diabetes, this is one of the original data from our center, and I feel it is very much applicable for our population. We have around 101 pregnancies, and they have first trimester, they require around 1.5 unit per kg body weight. And by third trimester, as the pregnancy progressed, the dose has gone up to around 0.8 unit per kg body weight of their pre-pregnancy weight. This for type 2 diabetes. Now, the dose, if you see in 3 different groups of GGI, that is gestational glucose intolerance, GDM, and pre-gestational diabetes. In the first trimester, they may require, those who are requiring insulin to achieve good glycemic control, they may require around 0.1 unit, 0.25 and 0.5 unit respectively. And as the pregnancy advances, it went up around 1.5 times from 0.1 to 1.15, 0.25 to 0.4, and 0.5 to 0.8 in gestational diabetes. In pre-gestational diabetes, type 2. Insulin regimen, people do suggest a premixed insulin can be given, but if it is a pure gestational diabetes, it's typically a postprandial hyperglycemia and better to give 3 times a day prandial insulin to cover post-breakfast, post-lunch, post-dinner. Glycemic control was better with 4 times a day, that is basal bolus insulin, rather than premixed twice a day insulin. There is typical, very rare data, which was again published by us from our center, twin pregnancy. This we got stimulated through this paper, which has come from US. The type 1 diabetes requiring double the dose of singleton pregnancy in twin pregnancy. And we have seen that we have not observed this, that twin pregnancy requiring higher dose. So we have collaborated the center with Nagpur and Pune, and we found that around 44 pregnancies where GDM women with twin or singleton gestation differed insignificantly in their treatment strategies with and as well as insulin doses. Insulin requirement need not be proportional to the number of fetuses, and treatment should be planned to achieve a good glycemic control. Insulin dosage should be always individualized. Mathematics possibly may not play a big role here. My next question for a physician is intrapartum management of a case for hyperglycemic pregnancy. Try to achieve blood sugar between 70 to 120. And if it is most of the GDM women will not require any insulin at the time of intrapartum phase. Pre-gestational diabetes type 1 and higher dose of insulin with type 2 may require insulin infusion, and try to achieve 90 and between 70 to 120 to avoid neonatal hypoglycemia. The last second concern is postpartum follow-up of a woman with gestational diabetes. Almost 15% of the GDM women may remain glucose intolerant immediately after delivery. 85% will become normal. Around 30 to 70% are likely to become GDM again in the next pregnancy. Around 50% of them will become diabetes next 5 years. So your focus should be assess them regularly. Breastfeeding should be encouraged. Contraception should be advised. Dietary modification and postnatal or post-pregnancy weight gain is one of the important concerns in our population that has to be prevented to prevent them developing from diabetes in future. There's another test. We recommend that 6 day, 6 week, and 6 month and once in a year should be the protocol for OGTT or a screening for diabetes in these women. It's called as rule of 6. But there is a recent recommendation which says 2 days postpartum compared to 4 to 12 weeks postpartum glucose tolerance testing may be good for pregnancy diabetes, almost with the 100% adherence and a good sensitivity and specificity. Breastfeeding, there is an inverse association between the duration of breastfeeding versus type 2 diabetes women in Paris women. So if you have a longer breastfeeding duration period, then the development of type 2 diabetes can also be prolonged, and we are protected. The mother is protected. Glucose lowering therapy during lactation. Insulin remains the drug of choice, but there are some data available for metformin and glipizide, and insulin still being preferred. Preconception counseling for those women who are pre-existing type 1 or type 2 diabetes. Young women aspiring for pregnancy is on rise. Most of the women with diabetes can get conceived. Dedication towards blood glucose monitoring, glycemic control is must from preconception till breastfeeding. Preconception counseling is must for all women with diabetes of childbearing age. Screen them for microangiopathy, macroangiopathy, and if they have PDR, if they have severe neuropathy, if they have coronary artery disease or other pre-existing severe proteinuria with nephropathy, in such patient we have to have proper assessment and then only allow for them pregnancy. Stop all oral drugs except metformin in few cases, and ARBs, ACs are contraindicated, statins are contraindicated. Achieve your target on insulin and if required metformin to less than 90 and 120, HbA1c bit less than 6, if possible at than 6.5 in type 1 up to 7. See for indications and contraindications for pregnancy, and that has to be properly assessed. I always say all physicians to please give fitness to to the patient who's coming to you for preconception counseling. Unless and until you give the fitness, like you give fitness for surgery, you should also give fitness for pregnancy. Then only a woman with diabetes should get conceived. That is the best way of having a best fetal neonatal outcome. But unfortunate part is 90% of the diagnosed pregnancy are accidental, and sab galti se ho gaya, and that galti se ho gaya, it has just happened. We were not aware of it. We should be prepared to face this challenge. Also, when someone coming to with 8, 9, and 10 and 12 HbA1c with around 7-8 weeks of pregnancy. This is my last part of the session. Maybe another 1 minute or so. What physician must know about diabetes and pregnancy. They have heard about all the academic part, but most important, I feel, is education and our social responsibility as a clinician. We should try to give education to our people and the population that they should be made aware about gestation diabetes. And that's why Government of India is the only country. India is the only country where we have we have now recognized 10th of March as a GDM awareness day by Government of India. No other government in the world has recognized the GDM awareness day, and we should have good awareness program like RSSDI is doing and DIPSI is doing at different platform. National GDM Day, we should do something. We have done some such programs, which is called a Diabetes Prega Talk, which we are doing every Wednesday. And we have done in different 21 different languages. We have completed almost 30 programs up till now. And it is they were taken in different languages. So we have started from English, Hindi, and Marathi, and Gujarati to Oriya, and even Tamil, all South Indian languages, even Kashmiri, Dongri, Konkani, and other languages. And I feel such programs are important. My last slide is the long-term outlook of the offspring of diabetic mother. If the glycemic control can be maximized to the extent that fetus no longer recognizes its mother has diabetes, then the treatment of mother during pregnancy may become the first step in the prevention of obesity and diabetes in the offspring. So we have to be aggressive. We have to be watchful. Ek jaan se bache do jaan. And there's a new slogan with DIPSI. During my presidency, we have promoted this, that we should do just one test and you can actually save 2 generations. GDM to type 2 diabetes is a window of opportunity, and we as a clinician should never miss it. Finally, before I stop, let me wish you all very happy Merry Christmas, Happy New Year, and in advance, stay safe, stay healthy, keep smiling, always celebrate all the occasions, whether it's birthdays, anniversaries, or any occasion, whether it's APICON 2022 of Odisha. Celebrate it by cutting the fruit and not cutting the cake. This may give a better message in the society that most of the cakes and pastries, they contain actually hydrogenated fat, which is not a good fat. With this, I stop here. Thank you very much for your patience listening. If you have any questions, they are welcome. I'll just try to, and share the slide, please. Doctor, you're muted.
Sunil Gupta, good evening. Share. Sir.
Yeah. Good morning, sir. Good morning. Yeah. I feel you are muted. Sir, you are muted. The person who's moderating from Hall B is muted. Yes. Yeah.
Thank you, sir. Any question?
How are you, Palinappam? How are you? All good?
Fine.
Sir, it was nice listening to you, Dr. Ashekar, sir. I heard your full lecture, sir. Thank you very much.
Thank you.
Enjoyed it.
Ashir Murstinga, sir.
Now the session is closed. The next session will start.
Already we are short of time.
Anupam, show your face.
Yes, also finished.
Good evening, Anupam.
Next is yours.
You went to Odisha, va? Anupam? You are from online lecture only. Anupam, please unmute.
Anupam has online only. So though today I feel it is online and tomorrow it will be virtual, physical.
Oh, okay.
Thank you. Palaniappan schedule is now.
Over to the organizers here.
Good evening, sir. Welcome to Dr. B. Palaniappan. He is a Managing Director of Diabetes Specialist Center, Sri Sakti Vinayakar Multi-Speciality Hospital. He was National API Vice President up to 2022-2025, National API Governing Council member from 2019 to 2022, and he was from 2014 to 2017. He has received the prestigious 2017 Alumni Award from PSG and Sons Charities Coimbatore. He will be speaking on management of diabetes in elderly. As we know, the diabetes in elderly is having difficulty in diagnosis as well as in management because they are not compliant. So let us listen from Dr. B. Palaniappan. Welcome, sir, to speak on this diabetes on elderly. Welcome, sir.
Can you see the slides? Huh? Hello?
Hello?
Yeah, can you see the slides?
Yes, we can.
Yes.
Yes.
Yeah, good evening, everyone. Good evening, ladies and gentlemen. Thank you very much, my dear friend Jain Panta, for giving me this opportunity. Thank you very much, chairpersons, for their kind introduction. Today, my topic is management of diabetes in older adults or elderly. And I am going to discuss in the 3 E's, that is evidence-based medicine, experience-based medicine, and expert-based medicine. Here is the slide source. Prime Minister Narendra Modi, he is young old, and his mother is old. So here, management of diabetes in elderly, whether the patient is young old or old, depends upon that, the criteria, treatment, everything will be modified. So the recent 2022 guidelines wise, there are 3 important criteria to manage elderly population, whether the patient is category 1, 2, or 3. 1 is functionally independent and 2 is functionally dependent, maybe frailty or dementia. Category 3, end of the life, bedridden, and you need help from help to manage all the things. So category 1, 2, 3 depends upon that. The treatment criteria also it varies. So elderly population between 65 to 69, the incidence of type 2 diabetes mellitus is 11%. And more than 65 years old type 2 diabetes mellitus patient, they are having autoimmunity, they are behaving as type 1 diabetes, 12% population. By 2030, Asia will be occupying the 50% of the diabetic patients. And if the age group is more than 65, the type 2 diabetes incidence is 53% in more than 65 years old population. If it is more than 45, 85% of the populations are 85% of the type 2 diabetes mellitus occupies more than 45 years old of age group. These are the various challenges in managing elderly population with type 2 diabetes mellitus. What are the challenges? Polypharmacy, renal impairment, irregular in exercise, irregular in meals, and hypoglycemic chance higher, and concomitant diseases like microvascular complication, macrovascular complication, various attacks, brain attack, heart attacks or limb attacks, cognitive impairment, altered in pharmacodynamics as well as pharmacokinetics, visual impairment, increased chances of fall due to hypoglycemia. These are the various challenges you have to address, and you have to find out whether these are plus or minus, depends upon that treatment varies. So pharmacokinetic, pharmacodynamics absolutely is different in elderly population because gastroparesis will be there, absorption will be delayed absorption, constipation may be there, or diarrhea will be there, urinary incontinence may be there, or retention of urine due to prostate will be there, and blood-brain barrier will be less effective. So concentration of the various drugs, especially insulin or sulfonylurea, will be more in the brain So you're more prone to develop hypoglycemia, glycemic unawareness is also higher chances. So all these pharmacokinetic, pharmacodynamic will be there. So if the action, duration of action also will be prolonged. If the patient is having renal dysfunction, osmotically, it will be running in the bloodstream for more than 3 days also. So sulfonylurea induced hypoglycemia will be prolonged in elderly population. So these are all the things you have to keep it in mind. Accordingly, you have to modify your prescription elderly population while managing type 2 diabetes mellitus. Polypharmacy. It's a single important thing you have to keep. All the physicians should keep it in mind. In my clinical practice, usually morning separate box, afternoon separate box, or night separate box. Separate box, you should keep the medicines. And 4 tablet, 3 tablet, 1 tablet, separate box, you have to keep it in a separate box. And usually my advice, take the medicines in the tabletop, and after taking bath, take the medicine and take the food. Before food, after food, many things it will confuse the elderly population. Most of the time they will forget because of loss of memory. So before going to toilet or before taking bath, take all the tablet, 4 or 5 tablet keep it in the tabletop and take the medicine, take the food. And many times they will get the call, everything, they will totally forget. So all the things you have to keep it in mind. And when you are giving the prescription, ask the patient to bring all the medications as well as the prescription before you modify your prescription. So all the BP reading or glycemic target, everything with the treatment or without treatment. So 1 dose missing, last 3 days missing. So compliance is very, very important. Topmost cause for there is resistant hypertension, poor glycemic control is compliance. Not used for the 2 days, 3 days, only OAD, no insulin, only insulin, no OAD. So all the things you have to keep it in mind before you modify your prescription. The topmost priority is don't produce hyperglycemia. That's very important, because hyperglycemia in elderly population, they may mimic as delirium, maybe hyper. Mood swinging will be there. Mood swinging, irrationality, appetite change, more appetite, increased appetite or low appetite, sleep disturbances, insomnia or oversleeping because of alcohol or because of sedative drug or antidepressant drug. So all the things you have to keep it in mind. If you don't treat hyperglycemia, they will end up in DKA or HHS. So these are the syndromes. That is elderly syndromes, depression syndrome or depression, polypharmacy, cognitive impairment, urinary incontinence, injurious fall, or persistent pain. So evaluating type 2 diabetes mellitus management, the evaluation should be physical assessment, overweight or underweight or obesity or morbid obesity, anemic or B12 deficiency, the hypothyroidism, subclinical or hyperthyroidism. All the things you have to assess properly before you give the prescription, proper, complete prescription, precision medicine for the particular individual. Neurological assessment is very important. Elderly individuals, we are coming across many patients with B12 deficiency, glossitis. One famous 86 years old famous neurologist, #1 neurologist actually, he is having vomiting and tiredness. His student went there and saw, he's a neurologist. He is suffering from glossitis, B12 deficiency due to the inadequate food intake and metformin induced. So after treating with B12 injections, patient, even the neurologists come out very well. And most of the time, there is a forgetfulness, loss of memory. They will not take more high, they will be, most of the time, they will be dehydrated. Dehydration itself precipitates depression, anxiety. So hydration is very important. And nutritional supplementation is very important. Presence and absence of anemia, it has to be corrected cautiously. And neurological assessment, even B12 deficiency, some patient may present with cervical cord compression, like quadriplegia also it may be there. Burning feet syndrome. Many things, peripheral neuropathy, radiculopathy, many things you can get it. If you simply treat B12 deficiency, simply treat vitamin D deficiency, completely, many patients will come out very well. Psychological assessment, anxiety, depression, mild, moderate, or psychosis, all the things. So psychological counseling, each and every visit, it's very important before managing type 2 diabetes mellitus proper. And elderly populations with type 2 diabetes mellitus, with morbid only, obesity only, you had to give them on orlistat or lifestyle therapy after that orlistat. Otherwise, better to keep, but don't reduce the weight unless it's very importantly, it's an indicator. And sleeve surgery, all the things, and dietary modification, strict diet control, please liberalize in the elderly population when you are managing obesity. Unless the patient is having morbid obesity and good support is there. And pre-diabetes elderly individual, don't treat like that, it will be there. My clinical experience is pre-diabetes symptomatic, peripheral neuropathy, distal polyneuropathy. You put them on metformin low dose 25 to 50 milligram. Or HLT2 inhibitor like dapagliflozin 5 milligram. It will be useful, but properly you have to teach them. And Gorbos off tablet 25 milligram tablet will be useful. So because of if you put them one of the drug, glycemic variability will come to normal, time in range will come to normal. So automatically most of 95% of the distal polyneuropathy will come down if you treat adequately, properly with the proper drug, which will reduce the glycemic variability. So elderly individual also pre-diabetes, you have to treat if the patient is symptomatic. And European Society of Cardiology or EASD guidelines also, elderly population also, the drug of choice, if the patient is having atherosclerotic cardiovascular disease, first drug of choice will be HLT2 inhibitor or GLP-1 receptor agonist after lifestyle therapy. After that only metformin, maximum you can give 1 gram. For elderly individual, especially more than 65 years, because elderly individual, maximum tolerable dose, advisable dose is in my clinical practice 1 gram. But some patient he can go for 1.5 gram. But elderly patient less than 65 years, he can go maximum 2,850 grams, 2,000 milligram. So these are the important thing. Guidelines says 2022 guidelines and various when the patient is having want to reduce the risk of hypoglycemia or want to reduce the weight gain, you have to choose HLT2 inhibitor or GLP-1 receptor agonist. Nowadays, semaglutide oral GLP-1 receptor is available. It can be useful, but slow and steady. Start low dose, slowly you up titrate. That is the slogan I want to give it to the elderly population's diabetes management. And other drugs, DPP-4 inhibitor or AGIs, other thing, elderly population as far as possible, glitazone should be avoided because 3 important things: elderly individual osteoporosis, fracture is very common, especially postmenopausal female, and especially elderly population, glitazones, the fear of prostate cancer, bladder cancer. So you have to keep it in mind. In my clinical experience, 80% of the even low dose pioglitazone can produce 5 kg, 10 kg maximum I have seen. So I am scared to use glitazone, especially in the elderly population. Please don't use. And trial and error is very important. It's up to you to decide. And other sulfonylurea and insulin, very important. You start with very low dose and slowly update it, depends upon the SFBG reading. Insulin also, basal insulin, basal plus 1, 2, 3 or basal bolus therapy, depends upon the SFBG reading only. So elderly population with type 2 diabetes mellitus, don't give diabetic diet, give usual diet. Don't restrict on the diet because it will produce depression. Many times hypoglycemia, it's a very dangerous thing. Hypoglycemia, hypertension is much more dangerous than hyperglycemia and hypertension. You have to keep it in mind. And A1C target should be less than 7.5 as far as possible, less than 7% in usual patient. Here less than 7.5% or 7.5 to 8.5% depends upon the comorbid conditions. And postmortem usually 85 years 185 and 90 years 190 plus 200 to 10 also you can keep it. Fasting better to keep elderly individual 110 around. If you want to stick control more, if the patient is educated and cooperative and well educated, you can keep tight control is useful. But you have to be very cautious in prescribing all these medications. And older individuals, diabetics, and exercise, elderly population, if there is a patient is having various contraindication will be there in doing aerobic exercise, resistant exercise. So best exercise in the elderly individual is flexibility exercise. Flexibility exercise will be best thing. And aerobic exercise, resistant exercise depends upon the fitness of the elderly individual. Before prescription, you have to keep it in mind. And sulfonylurea is concerned, the best drug in elderly individual is glycoside or glipizide. Third only glimepiride. Glimepiride start with even 0.5 milligram of tablet OD, slowly up titrate if necessary. An elderly individual, meglitide 3 times a day also useful, or major meal he can use, and chances of hyperglycemia is lesser, and suddenly duration of action also meglitide is lesser, but cost will be higher on comparing with the others. So particularly these are the things very important. Elderly individual, please don't use that is dianyl tablet, glibenclamide, please don't use. And insulin also very cautiously you have to use, and glitazones you have to avoid. Use detimer or glargine as a basal insulin instead of human insulin, but it depends upon the packet many you have to use. NPH and human insulin, still elderly individual, because of the poor individual, you have to use at all human insulin, mixed insulin, and pre-mixed insulin will be better, and pre-filled insulin will be better instead of mixing the insulin. Nowadays almost it's gone. Analog insulin we are using. And clock drawing is very important, vision is very important, understanding is very important, and regular diet you have to advise, and checklist, avoid hypoglycemia, and regular diet, and individualize the goal. And these are the usual guidelines. The A1C basal insulin starting dose is usual guideline is less than, if the A1C is initial A1C is less than 8, 0.1 to 0.2, more than 8%, 0.12 to 0.3, more than 8% basal bolus insulin or basal blast insulin, 0.3 to 0.5 units per kg. In that total dose, you have to divide into 50-50%, and basal bolus insulin 50-50%, basal insulin 50%, brandial 3 divided dose you have to give. Here you have to be very cautious. If the elderly individual more than 200, add 10 to 20%. Elderly individual, but others 20%, here 10 to 20% or 1 or 2 units. Adjust accordingly. Every third day you have to titrate and keep the goal. And safety of the insulin, detimer, and it's useful. Declutec can be useful, and insulin declutec phosphate combination is also very much useful. Chances of hypoglycemia is lesser, and nocturnal hypoglycemia is very, very lesser when you are using insulin declutec phosphate combination, that is co-formulation insulin, but affordability. Now the cost is 40% lesser on comparing to the previous 3 years. So combination analog insulin or analog insulin or co-formulation insulin will be better choice for elderly individual diabetic patients, and very common chances for hyperglycemic hyperosmolar state. So here hydration is very, very important. You have to give more fluids unless it's contraindicated. Whether the kidney is okay or heart is okay, no heart failure, you can give rush the fluid. But these things very, very common, mild, moderate, severe. So you have to keep it in mind. Hydrate the patient, insulin slowly infuse, you give the IIT therapy, but every hour you should not reduce the blood sugar between 30 to 50. Sudden drop will precipitate death. Metabolic, various cerebral edema can precipitate. So you have to be very cautious. Slowly you have to keep that things. And hypoglycemia unawareness is very common in elderly individual. It may result in these all the causes of hypoglycemia in the elderly population. That is reduced count regulatory hormone effect, renal hepatic changes will be there, hydration will be poor, autonomic neuropathy, polypharmacy, intake of alcohol or sedative drugs, inadequate nutrition or irregular diet, decrease intestinal absorption, motility, everything, all the common causes for hypoglycemia in elderly individuals. When you have to keep it in mind. So if you precipitate hypoglycemia, they will go to some other doctor, or death can occur due to sudden cardiac death, cardiac arrhythmias, arrhythmias, atrial fibrillation, sudden death can occur, and brain cortical necrosis can occur. Risk of fall also very high. Cognitive dysfunction, memory dysfunction is common. So these are the neurogenic symptoms, neuroglycemic symptoms. This is the your criteria to diagnose hypoglycemia. Level 1 hypoglycemia less than 70, level 2 hypoglycemia less than 44, level 3 less than 44, plus mental or physical altered status requiring the help, assistance is the level 3 hypoglycemia. In your prescription, hypoglycemia, don't mention level 1, level 2, level 3 hypoglycemia. What is the cause? How you have manage. Like that, you have to give the prescription and recognize, differentiate from other causes. Elderly individual fall, subarachnoid hemorrhage or subdural hematoma, EDH, cerebral edema, many things may be there the cause. So you have to differentiate with the other causes, treat hypoglycemia, don't overtreat, avoid hypoglycemia in future. And after that, recognize and confirm and give simple carbohydrate if the patient is conscious. If it is unconscious or semi-conscious, give infusion and retest every 15 minutes till you get the level more than 70 milligram. And eat usual mixed diet after treating hypoglycemia. These are the 15 gram of simple carbohydrate, 4 tablets or 3 teaspoonful of sugar or 6 packs. This sugar cubes or honey 1 teaspoonful. These are all the lifesavers. All the elderly individual in the bed itself, you have to keep all these things. One of the things you have to keep, and glucagon also should be with the side. The attenders and patient relatives should know 1 milligram of glucagon. Unconscious patient immediately IM and send to the patient. Take the patient to hospital and treat accordingly. If the unconscious patient, 100 ml of 25% dextrose or 50 ml of 50% dextrose or 250 ml of 10% dextrose or 1 pint of 5% dextrose. This is all the treatment. After that 15 gram of regular carbohydrate, simple carbohydrate. After that, mixed meal. And these are all the various steps you have to treat accordingly. And profound hypoglycemia, I want to give some tips. If the profound hypoglycemia is its meaning is more than 12 hours of that's hypoglycemic unawareness, not treated properly. If it is more than 2 to 3 days, it will end up in brain cortical necrosis. This individual, 25% dextrose, give 1 point, again 1 point, not controlled, not recovered, fits everything, seizures, everything not controlled. Dyslipidemia, it has to be corrected. Then the source of the hypoglycemia, various drugs, ofloxacin, levofloxacin, azithromycin, all the things stop everything. Before that, the insulin stop or reduce the dose. Sulfonylurea stop. Sometimes sulfonylurea in the GH medicine, glibenclamide, small tablet, maybe B complex like that, the overdose will be there. So you have to see the various tablet prescriptions in the elderly individuals. Common problem is sulfonylurea unmonitoredly they have taken. And if this is not responding properly, give amantadine, Admenta, and cerebrolysine also. Pediatric age group is mannitol is useful, and off-label indications, dextran can be useful in profound hypoglycemia. 99% they will recover if you treat properly, if you address in this manner. And food screening is very important. Elderly diabetic patients, nail cutting and callosity, indoor, outdoor, chapel is very important. Any changes, skin changes, color changes, it has to be properly. They have to watch every day after taking bath, apply simple coconut oil or liquid paraffin. And some emollient, soothing agent you have to apply daily. Don't apply in the web space, and keep the area clean and dry. That's very important to prevent fungal infection and various chances for various injuries. And nail cutting, they should not do the nail cutting, even though they are conscious, well-versed. Ask the attenders to do, or get for help many times. That's very well. Cutting the nail, injury is very common. Fall is very common. And for deformity, it has to be corrected properly. Indoor, outdoor, that footwear is very important. And offloading by the diabetic non-healing ulcer, whether it's a peripheral disease or distal polyneuropathy induced, depends upon that. The treatment varies. And nephropathy nowadays, HLT inhibitor you can give. That is empagliflozin. You can give up to EGFR of 20 also you can give. As the elderly individual, 4 important things when you are prescribing HLT2 inhibitor. First is hydrate adequately. Extra 500 to 750 ml they have to take. And no salt restriction for the first 1 month. After that, you can restrict. A third thing is genital mycosis, very common. So the treatment of choice is good glycemic control and keep the area dry. 90% it will come down. And 10% of time only you have to apply antifungal therapy or oral antifungal therapy in elderly individual. So teaching is very important. Personal hygiene and keep the area dry is one of the important secret in while prescribing HLT2 inhibitor, whether DAPA or canagliflozin or empagliflozin. Elderly population, EMPA scores over because cardiovascular mortality benefit will be much better, but only problem is afford this cost. They are reducing the cost. It will also come to a price control. So these companion drug, the HLT2 inhibitor, actually reduces the albuminuria, prevent the decline in the EGFR. These two important effect is there. And finerenone you have to use to reduce the risk of anti-inflammatory action and anti-fibrotic action, both kidney and heart. So it also can be added provided it's indicated. So retinopathy also screened properly, whether it's a non-proliferative or proliferative retinopathy or macular edema or hemorrhage, laser treatment, various treatments are there to prevent vision loss. So every 6 months or every year or once in 2 years, depends upon the presence and absence of the diabetic retinopathy and hypertensive complication. All elderly population, every year, influenza vaccine, pneumococcal vaccine, more than 45 years, both PVC 13 and PPSC 23, combination, single sitting you can give. Less than 65 years, 5 years gap. And other various pneumococcal vaccine and influenza, these two is very, very important. And hepatitis vaccine is very important. 013 is very important. Here is the patient Lakshmi. The problem is burning feet syndrome. Burning feet syndrome, glycemic control is very important. So HLT2 inhibitor plus or minus sulfonylurea, other things it's useful in this patient. This patient Palaniswamy, here peripheral, there is proliferative diabetic retinopathy, elderly individual, poor glycemic control, CKD stage 3. And patient is on glibenclamide, pioglitazone. Stop pioglitazone and glibenclamide don't use, if at all, the drugs HLT2 inhibitor or GLP-1 receptor agonist. Third is metformin. Fourth is glitazone. Then fourth is that is AGIs. Fifth is glitazone. Fifth is that is DPP-4 inhibitor. After that, low dose of sulfonylurea. So this should be the formula you have to use. So here you cannot use especially glitazones. But HLT2 inhibitor, he can use in this individual, he can use with caution, because osteoporosis is, whether it's there, low dose, he can use HLT2 inhibitor. So to conclude my talk, elderly individual diabetic management, it's a comprehensive management, and you have to treat not only diabetes, hypertension, and obesity, dyslipidemia, and other comorbid condition, microvascular complication, macrovascular complication. Depends upon that only the selection of drug is there. So cost also very important, and you have to keep the A1C less than 7.5% or less than 7. Depends upon the purely it's a patient centric, the elderly individual. And this is all the thing I have discussed. To conclude my talk, glycemic target is very important. Avoid both hyperglycemia and hyperglycemia. Equally important. Hypoglycemia is much more important. It is individualized. Depends upon the presence of comorbid conditions. You have to choose the drug, and don't overtreat the patient, elderly individuals, as well as don't undertreat also. De-intensify the treatment. Start low dose, slowly uptitrate, especially insulin and sulfonylurea. Especially if you want to use glimepiride, start with 0.5 milligram tablet, also off tablet, slowly uptitrate. Especially sulfonylurea, insulin, low dose in the bedtime. And purely depends upon the SMPG reading. And to finally, the quality of life is very important. The strict control, better to avoid. Quality of life is very, very important. So elderly individual, hypoglycemia, you have to watch. Other comorbid conditions, you have to treat properly. Insulin, sulfonylurea, very safely you have to use. The patients are affordable. Analog insulin is much more useful. So this will increase the longevity. And co-formulation insulin, if the patient is affordable, definitely is the drug of choice in the elderly individual when you are using insulin, because nocturnal hypoglycemia very less, hypoglycemic chance also very, very less. So this is also very important, and according to the economic status also you have to keep it in mind. So especially all the drugs, HLT, elderly individual, many people, they may say very cautiously you have to use. I have enumerated 4 things. Repeating again, hydration should be adequate, salt restriction should not be there, keep the area dry, and personal hygiene is very important. Good glycemia itself, all the genital mycosis will come down. If you want to treat, after that only antifungal ointment or tablet. These all the things, it's very important. Start with the low dose, slowly up titrate. Oral GLP-1 receptor agonist also low dose, slowly up titrate. These all the things, secrets. And thank you very much for the patiently listening. Thank you very much.
Thank you, Dr. Palaniappan, for your lucid, vivid talk about diabetes in elderly. Still, the treatment of diabetes in elderly is challenging because they are non-compliant and they are having cognitive dysfunction most of the time. So, thank you, sir, very much.
If any question, I am ready to answer because I have to leave. Any questions from the audience?
No questions, sir, please.
Yes, sir. Yes, sir.
Can I ask?
Yes, sir. Yes, sir. Bharat Maningra. Yes, sir.
Okay. Thank you, Dr. Paneli. Really a nice and very vivid talk. Almost covered everything. I have got a small comment regarding your exercise. Okay. So regarding exercise, you have told that weight-bearing exercise or aerobic exercise. I think you have shown 3 categories. So in category 1, when patient is fit, there is no contraindication of going any of sort of aerobic exercise or weightlifting exercise or your stretching exercise, because these are all not contraindicated. This should be encouraged. Patients who are frail, yes, fine. But who can do, suppose I am 70, but I am able to do everything. I am going to aerobic exercise, I am doing weightlifting exercise, I am doing everything. So my point is, yes, patient who can do safely, they should be encouraged to do safely. That is the recommendation. I am not taking that is the recommendation.
No, sir, you are absolutely right, sir. Many individuals, more than 50% of the elderly individuals, those who are 70, 75 also, twice a day walking, I am encouraging. Gives a lot of, it reduces the depression if it is indicated. But at the same time, you have to keep a watch. Let's say heart attacks, reduce ejection fraction, even heart failure patient with a good control, definitely walking should be encouraged. But resistance exercise, you have to get the fitness. And flexibility exercise, universally you can do whatever the conditions you are having. But physical fitness is very important. TMT, 256 slice, 50 slice CT angio, everything, please do it. And if your heart and kidneys are safe, no issue at all. And fundus is safe, no issue at all. If the patient is saying proliferative retinopathy and macular edema, severe peripheral neuropathy, fall very common. You are fit, you are absolutely right, sir.
The second thing regarding use of SGLT2 inhibitors, you see, almost most of the trials, most of the RCTs, they do not include patients more than 75 years. Okay. So what is your comment? Patients who are more than 75 years. So using SGLT2 inhibitor in them, what is your comment on that?
Sir, there is no guideline says SGLT2 inhibitor is contraindicated if the age is more than 75. Even the SGLT2 inhibitor, especially empagliflozin, it can be used even the EGFR more than 20 itself. So important thing is hydration is very important. And my advice, even 75 years old population, I am giving dapagliflozin 5 milligrams start with, not 10 milligram, 5 milligram. And we have to give the advice. Hydration should be extra 500 to 750 ml. Water you increase. Even if you are having anti-hypertensive therapy, salt liberalization for the next 1 month, and lemon soda and buttermilk with salt. Advise them. And after that, after 1 month, they will get into that. They will get the benefit. After that, they will feel if they want to reduce the salt, they will get accustomed with the DPP. That's a SGLT2 inhibitor. Definitely, it's indicated. I am using it's a novel molecule. Many people are scared to use. I am using plenty of drug, plenty of patients in elderly population. It works out fantastically very well. No guideline says it's contraindicated. Use with caution. That's all.
That is why 1 minute. That's why it is included.
Yes, sir.
Yeah, it is included in the Fantastic Four. That is especially in the heart failure. That is beta blockers,
Yes,
ARNI,
one of the pillar.
angiotensin neprilysin inhibitors, and mineralocorticoid receptors. Last but not least is SGLT2 inhibitors, gliflozin. As he says, there is no contraindication. Only thing is we have to be careful about the genitourinary infections. And another point, we have to be careful about the normal diabetic ketoacidosis. That is the normal euglycemic diabetic ketoacidosis. That we have to keep it in mind. Some patients will develop euglycemic DKA. That we have to keep it in mind.
Yes, sir.
Yeah, that is the important point. Another point regarding exercise, the so-called FIT principle: frequency, intensity, type, and timing of exercise. 150 minutes in a week, or 30 minutes 5 days in a week, or 20 minutes per day in a week. What is endurance exercise? I like swimming. That is my endurance exercise. Dr. Palniappan like jogging. That is his endurance exercise. Only thing is, patient in failure, coronary artery disease, in high altitudes, don't ask them to go for jogging and all. That is the important thing. Swimming is the best exercise. It does not influence the absorption and all. That is very important. That is especially insulin absorption. Thank you.
In HFrEF patient and a preserved ejection fraction also, HLT2 inhibitor is the class 2A indication. Even ARN is 2B indication, preserved ejection fraction patient. Even the presence of diabetes or absence of diabetes, 2A indication. So elderly individual definitely nowadays HLT2 inhibitor, not a diabetologist molecule, cardiologist molecule, nephrologist molecule.
Thank
Yes,
you,
sir.
sir. Bharat sir, thank you for question. Let us conclude here this session. Thank you, Dr. Palaniappan.
Thank you.
We'll
Thank
go
you.
to the next topic.
Thank you. We will see you
Yes,
in
sir.
Ahmedabad.
Yes, sir. See you, sir.
Good evening, sir. I welcome on behalf of APICON State Odisha State Chapter to Professor Dr. Prabhat Pandey, EGMD Medicine, FCCP, FICA, and Professor in Medicine and from Sri Shankaracharya Institute of Medical Science, Vilai. Now he is as a consultant physician, trained in also clinical cardiology, and is a member of fellow in Cardiology Society of India.
Am I audible? Am I audible?
Yeah, you are audible.
I think we can go ahead.
And he is a life member of Nation. Now welcome him. Everybody knows what is the enteric fever. It's a fever, continuous fever caused by Salmonella typhi and paratyphi, and every physician knows the treatment of enteric fever. But now it's very tough to treat the multi-drug resistance type of fever. And I hand over mic to Dr. Prabhat Pandey to describe what are the treatments of multi-drug resistance type of fever. Welcome, sir.
Thank you very much, and thanks to the APICON team of Odisha for having me given a chance to speak on this Odisha State APICON. Thank you very much, Dr. Jain Panda. And I have been given task to speak about the enteric fever. All of us know very well about this topic, and I have treated enteric fever or fever patient likely to be enteric fever in hundreds and thousands in our career. But I would like to highlight some of the important points about it. So please go ahead. We know that there are two kinds of causative organisms for enteric fever. One is a typhoid, another is a paratyphoid, and it's a gram-negative organism which is caused. Typhoid fever is caused by Salmonella typhi, and paratyphi A and paratyphi B cause the paratyphoid fever. It's written parathyroid. I'm sorry. Next. The prevalence of the types: type A is the most common pathogen, which is seen worldwide. Type B is predominates in the Europe, and type C is a rare, which I have yet not seen, or it's only seen in the far east of the places. Next. Now, how to nowadays it's a big problem to actually diagnose, to actually confirmly diagnose about the enteric fever. And every now and then we come across the patient saying that he is having a typhoid fever, and every Vidal test is considered to be an enteric fever positive. So let us understand. So paratyphy A and B is estimated to cause 76% of the enteric fever globally, and the confirmed enteric fever is considered when the fever is more than 38 degree for the last 3 days with a laboratory confirmed positive culture, especially the blood culture of the Salmonella typhi, which we rarely do it in our clinical practice in day to day. So we normally land into the probable enteric fever diagnosis in which the fever is more than 38 years over 3 days with a positive sero diagnosis or antigen detection test, but without the Salmonella typhi isolation. And third is a chronic carrier state, which is excretion of the Salmonella typhi, which is seen in the stool and the urine. Next. Now the incidence of enteric fever in India per 1,000 is shown over here. It is most commonly seen in the age group of 5 to 15 years, which is evident in this graph. Next. Yeah. So you can see this slide, the prevalence of enteric fever in India. This is shown between less than 15 years of seropositivity rate is also seen here. Next. Now, factors which affect the epidemiology. The incidence of the enteric fever in endemic area is typically low in the first few years of the life and peaking in the school-aged children and the young adults, and then falling later in the middle age. And the older adults are relatively resistant, probably due to the very frequent boosting of the immunity. Next. Now, the factors affecting the epidemiology is this, definitely the season. The endemic area peak transition occurs in the dry weather or at the onset of the time. And similarly, it is seen in the warm and moist conditions. So for all practical purposes, nowadays enteric fever doesn't have any seasonal variation, but is seen almost throughout the year and more so in the endemic areas. Next. Now, which factors which affect the epidemiology is definitely the food habits. We know that it is transmitted through the contamination of the water and the food. So eating the food prepared outside the home, the different kind of ice cream, drinking water. So basically it is a contamination of the food articles. Next. Now the factors which affect the epidemiology. A close contact of the relation with the recent enteric fever, the poor socioeconomic status, high population, poor personal hygiene, the lack of sanitation, lack of water supply, clean water supply, and the low latent kind of use. Next. As per the chart, you can see that it constitutes a very small percentage of the variety of diseases which we see all across. So that is why it is not given so much of importance, and more so because of the so many antibiotics have come into the picture. The enteric fever has not become fatal, which it used to be something around 2 to 3 decades back. So one thing that it constitutes a very small percentage, and secondly, you see that it causes hardly 0.9%. And secondly, it is no more a dreaded or a fatal illness nowadays with the advent of so many antibiotics. Next. Now the diagnostic approach. Next. The clinical feature, first week is a typical presentation of the fever, exhibits a step ladder pattern, of course, rarely seen nowadays, because the moment the fever starts in 2 to 3 days, patient starts consuming some antipyretics or some antibiotics. So this typical pattern is not seen, but is still described in the books that this is a step ladder pattern. The temperature rises over the course of each day and drops by the subsequent morning, and the peak and troughs rise progressively over the period of time. Next. The gastrointestinal symptom, then the other respiratory symptoms, they are also the associated finding in case of enteric fever in the first week itself, along with the fever. Next. Next, please. Now the second week, the rose spots, they are the typically described in the textbook, but nowadays rarely seen for the reason because By this time, if the fever is left to reach to the second week, probably you might see it, and if it is a confirmed enteric fever. But as I said, with the starting of the fever in third or fourth day, patient starts consuming the antipyretic and the antibiotics, and the whole pattern in the system of the development of the enteric fever and its progression is deranged, and this kind of a clinical picture is rarely seen. Next. The third week, fever persists, increases, toxemia, anorexia, weight loss, conjunctivitis, and this is typically caused as a characterized by typhoid state, and it leads into the involvement of the brain and it starts causing apathy, confusion, and the psychosis. Next. Fourth week, the gradual improvement does occur in the fever, mental state, and abdominal distension. If untreated, patient may suffer from the intestinal and the neurological problem. Weight loss and debilitating weakness may last for months later, even after the recovery. Next. Now the blood culture, the most of the time, the first week, 90% it's positive, and second week, 75% the blood culture is delayed. Probably its specificity and sensitivity is lost. The PCR chain reaction is also one of the important diagnostic tool. It's a promising test, but as sensitive as blood culture, but less specific, and it has been found to be more than 90% sensitive and relatively simple to perform. Next. Now, investigation according to the week of presentation. Normal routine hematological picture is done. The first week, the second week, also first week the blood culture has an important Vidal, basal Vidal, and normally the blood Vidal which we come across every day starts coming positive in the second week. And the third week, various kind of hematological tests, USG, abdomen, and these all tests can be done. And the fourth week, if a patient remains untreated, all the combination of the test can be done. Next. Intestinal complications used to be one of the very important complications of the enteric fever in earlier days, and that is why it used to be threatening and probably dreadful and fatal. It ranged from something as benign as a glossitis or an esophageal ulcer to a problem that can prove fatal, such as intestinal perforation, which was a very serious complication of the enteric fever in earlier days. The extraintestinal complications, CNS involvement, it causes encephalopathy, encephalitis. The cardiovascular complication, this myocarditis, pericarditis, endocarditis, heart failure, pulmonary compression, hepatobiliary combination is a very important and most likely complication which causes cholecystitis, hepatitis, and hepatic sepsis. Genitourinary complications, soft tissue, and hematological. Of course, these all complications are rarely seen, as I said earlier, because of the involvement of the so many antibiotics, but hepatobiliary complications are still seen nowadays, and which lead to the chronic carrier complication, chronic carrier state. The management part. Next. The various drugs have been found to be effective in the enteric fever. Uncomplicated enteric fever, quinolone sensitive patients, we know all very well, fluoroquinolone have been long been used as a treatment. They are the various list of the drugs. Then quinolone resistant areas, the ceftriaxone group and cefixime has been tried. Azithromycin is still a drug of choice. Next. Now, symptomatic and the supportive care. Along with the drug treatment, what is required is a symptomatic and the supportive care. Maintain adequate hydration because it causes the gastrointestinal symptoms also. And corticosteroids have been suggested for the severe cases, normally not routinely being used. Next. Surgery, when it leads to a complication of enteric perforation, intestinal perforation, or when gallstones accompany a carrier stone, probably cholecystectomy is a choice, and a surgical repair is indicated for the complication, as I said. Next. Now the prevention, there's a long list of prevention which we know out very well. Nowadays the vaccine has come, and we know there are two types of vaccine, VIPS and the type 221A. One is a polysaccharide, another one is live attenuated. Well, we know it very well that nowadays we commonly use this kind of a vaccine which is injectable and parenteral, and the details of the vaccine are given. Most of us are very frequently using it, but the only thing is that people do not use it as a booster dose, and it is required to be repeated every 2 years for the people, especially who remain in an endemic area. The epidemiological data reveals that typhoid is more prevalent in the low and the middle class social income countries where there is a poor hygiene, poor drinking water, and the lack of sanitation. The safe drinking water sanitation is probably a better way to remain away from this kind of illness. Next. Now, the challenges in management is a multi-drug resistance. As I said, that in most of the cases, even if it is not diagnosed as enteric fever and likely to become an enteric fever, they start with a various kind of antibiotics right on the day of fever of 3rd, 3rd, and 4th, and then now that is why probably the antibiotic resistance has developed. And the worldwide distribution of the antimicrobial drug resistance in the Salmonella enteric is it's a very commonly seen, and that too in India also. Next. The incidence of antimicrobial resistance is in India is to the various drug you see, nalidixic acid, ciprofloxacin, and the multi-drug resistance of any 7%. Next. The rise in the prevalence of the multi-drug resistance is going high and higher for the last couple of years, and the last data was 2005, and when it was found to be 66%. Now the economic implication, of course, not very much related to us, and because to that level enteric fever has not gone to cause so much of a complication, in the sense that it is being treated quite an early, even at a lower places in the lower centers. Next. Now the relapse rate categorized by the bacterial drug resistance is seen over here. You see the initial therapy of exclusively ampicillin, chloramphenicol, or trimethoprim sulfamethoxazole, partial or full initial therapy with cephalosporin and quinolones. These graphs shows the pan sensitivity, the partial drug resistance, the multi-drug resistance, and the all kind of patients. Next. So the take-home message is that enteric fever is very common in the Asian countries, especially in India, and it's with a complication that can be both intestinal and extraintestinal. Strategies to reduce the disease burden include pure hygienic status, including the water and sanitary improvisation. Appropriate use of drugs like fluoroquinolone, cephalosporin, azithral are the important one. The early identification of the symptoms and the treatment reduce morbidity and mortality. And enteric fever is usually treated medically, and surgical interventions are really required. Next. Thank you. Thank you very much. If any questions are there, I'm here to answer. Yes.
Sir, please unmute.
Thank you, sir. No more questions from the audience, and very nice talk about the enteric fever and people will listen how to prevent and what are the vaccination and the treatment of multi-drug resistance enteric fever. Thank you, sir.
Thank you very much.
Thanks, sir.